pressing. Often called the silent thief, osteoporosis continues to compromise the independence of millions, yet our understanding of bone biology and preventive strategies has reached an unprecedented peak. Let us commence these sessions with the shared goal of making bone health a lifelong priority, turning the tide on osteoporosis through education, early intervention, and collaborative care.
We, on the behalf of Department of Anatomy, Government Medical College Dindigul, are proud to commence the upcoming academic sessions of OSTEOPREV 2026. We initiate our scientific odyssey by delving into the intricate architecture of skeletal vitality. This session explores the sophisticated equilibrium of bone modeling, a harmonious biological bone that sustains our structural integrity. It is a distinct honor to welcome our esteemed speaker, Dr. K. Parthiban Sir, Professor and HOD, Institute of Anatomy, Madurai Medical College, whose profound expertise will surely illuminate this subject. Alongside him, we are privileged to have our distinguished chairpersons, Dr. R. Uma Chamundeshwari Ma'am, Head and Professor of Pathology, and Dr. B. Sudha Prasanna Ma'am, HOD and Professor of Biochemistry, Government Medical College Dindigul, to steer our inaugural deliberations.
Good morning, one and all. First of all, I would like to thank the organizing committee for giving me this opportunity. For this session, I warmly welcome Dr. Parthiban Sir, the Professor and the HOD of Anatomy, Madurai Medical College, to deliver his valuable talk about bone formation and dynamics. Few words about Sir. He completed his MBBS degree in 1987 at Madurai Medical College, followed by Diploma in Child Health in 2001 at the same college. He also completed his master degree in anatomy in 2005 at the same college. He is an eminent anatomist and dedicated clinician with a strong academic background. He has published multiple research papers in the national and the international medical journals. Also, he has been recognized for his excellence in service and honored with the Best Doctor Award. Thanks for coming all the way, sir, and welcome you again. The stage is yours.
Morning, my dear students. Before starting this topic, I thank your professor, associate professor, for choosing me as a speaker. Now we are going to see the basic anatomical structure of the bone, classification of the bone, also the macroscopic and microscopic structure, and the formation of the bone. First, we take up the bone. The bone, it is derived from the osteon, it is a Greek word. Os, it means a Latin word, means bone. Definition. Actually, bone is a highly vascular, specializedly, constantly changing connective tissue, consisting of the cells and the intercellular substance, which are impregnated with the salts, inorganic salts. So most of the students thought it is a inert substance, but not so. It is a living structure. It is supplied by the blood vessels, lymph vessels, and the nerves. It has a greater regenerative capacity than any tissue of the body except blood. It always shows the disuse atrophy and the overuse hypertrophy. If you take the composition of the bones, about 95% of the composition is mainly from the extracellular matrix, that is otherwise called intercellular matrix. Cells, it forms 5%. Among the cells, you know all these cells, osteogenic cells, osteoblasts, and osteoclasts. Among the extracellular matrix, it is further divided into 35% is composed of the organic, and the inorganic cells constitute about 65%. Among the organic materials, further collagen contributes to about 35%, 31%, non-collagenous substance 4%. The collagen of this bone is called type 1 collagen fibers. It is called osteoid collagen. The non-collagenous substance consists of divided into glycosamine and glycans and the glycoproteins, you know very well. And if you take up the inorganic salts, it constitutes 65% of the total 95% of the extracellular matrix. Among the salts, calcium phosphate is the main component, 85%. Calcium carbonate is 10%. The remaining salts, sodium, other salts contribute about 5%. Functions, you know the functions of the bone very well. It provides support and shape to the body. It provides attachment to the muscles, tendons, and ligaments. It serves as a levers for the muscular action. Protects certain viscera, you know very well. Brain is protected by the skull bone, spinal cord is by the vertebral column. It is a site for the hemopiesis. It is a store of the calcium and the phosphorus. About 95% of the phosphorus is stored here, and about 97% of the calcium is stored in the human skeleton. It also performs the immune response because it contains the reticuloendothelial cells. Some bones around the bones filled with the air called paranasal cells, which affects the timbre of the voice. If we take up before going to we will know the classification, the first classification, the macroscopic classification of the bone. By the appearance, external appearance is classified into compact bone and cancellous or spongy bone. If you take up the compact bone, it is dense in structure, like ivory with no visible spaces inside. So it is situated in the cortex of the long bones, the shaft of the cortex of the long bones. It consists of the collagenous fibers and the well-developed osteon or Haversian system. These systems we are going to see at the later stage. It also contains if you take up the spongy bone, it consists of the rods and the plates of the bones with the numerous spaces between these. These spaces are filled by the bone marrow. The spaces provides the spongy appearance, so it is called spongy bone. They do not have the well-developed Haversian system. Before going to the other classification, we will see the parts of the growing long bone. It has the following parts: diaphysis, epiphysis, epiphyseal plates, metaphysis, outer periosteum and inner endosteum, marrow cavity within the diaphysis. If we take up the diaphysis, so we have seen the definition and the composition of the function. Now we are seeing the parts of the young growing bone. The diaphysis, it lies, dia means between, Greek word, physis means growth. It is a part of the bone that lies between the ends of the developing bone. It corresponds to the feature shaft of the long bone. It is ossified from the primary center of the ossification. The wall of the bone is composed of the compact bone. Inside, it has a cavity called a marrow cavity or medullary cavity. Now, we have seen the bone marrow cavity, so it contains the specialized tissue called bone marrow. What is bone marrow? It is a soft, loose vascular tissue consisting of the network of the delicate reticular fibers with various types of cells. It is the major site of the hemopiesis, as you know very well. Apart from the medullary cavity of the long bone, this bone marrow also present in the spongy bones present in the ends of the bone. The spongy bones are present in the ends. The bone marrow is of two types, red bone marrow and yellow bone marrow. The red marrow, it resembles because of this high content of the RBC, it is red in color, vascular, highly vascular. Consists of the network of the reticular fibers containing blood cells of all the stages of the development. immature and mature RBCs, myeloblasts, myelocytes, granulocytes, all these cells are present here. The yellow marrow consists of the only adipose tissue. Even though it contains mainly adipose tissue, it contains some amount of hematopoietic tissues which may be useful in certain conditions. The red bone marrow, it is present in the, if you take the at birth, it is present in the developing the embryo, it is present in the almost in the all the sides of the bone. At the age of 7, the yellow marrow starts replacing the red marrow in the middle of the shaft of the growing bone. Then it starts replacing towards the end. By the age of 20 years, all the red marrow is replaced by the yellow marrow. By the age of 20 years, after this, the red marrow contains only present in the following sites: the spongy bones present in the ends of the long bones, sternum, ribs, skull bones, and the iliac crest of the hip bone and the vertebrae. However, these red marrow are present in following sites. All the other tissues contain the yellow marrow only. In certain situations, hypoxia or severe bleeding, this yellow marrow contains the hematopoietic tissue which is transformed into the red marrow. So this is the main technique to contain the bone marrow aspiration. If we take the bone marrow, what is bone marrow aspiration? It is a clinical procedure to remove the bone cells and the fluids from the bone marrow and examine for diagnosing certain condition like leukemia, anemia, and thrombocytopenia. The common sites used for the bone marrow aspirations are sternum, anterior and posterior iliac spines, ribs, lumbar spinous process, and the upper end of the tibia. In children, usually perform the bone marrow aspiration from the upper end of the tibia. In adult, the iliac crest or sternum. If you take the bone marrow biopsy, it is different from the bone marrow aspiration. The procedure is same. Here also we are going to insert the needle to the particular sites. But here we are going to collect the solid core of tissue, bone marrow tissue. And is examined for the architecture and cellularity. To main purpose of this bone marrow biopsy, whether the carcinoma is primary from the bone or secondary from the elsewhere in the body. Also it is useful for the monitoring treatment. The bone marrow transplant, nowadays it is major development in the curing some diseases. It is a procedure in place. The unhealthy bone marrows are replaced by the healthy one. The healthy bone marrow are collected from the same individual or donor individual, and they are infused through the routine blood transfusion like. So this healthy bone marrow, through the IV, it reaches the bone marrow, it replaces the unhealthy bone marrow. It starts producing the fresh hematopoietic cells. So we used to treat mainly like leukemia, lymphoma, and the aplastic anemia. So it is the procedure where you can collect this bone marrow for the bone marrow aspiration. It is demonstrated, easy. So you have to do the procedure, what are the clinical procedure, you have to do under sterile aseptic conditions. Now, he is drawing the local anesthetics fluid, he is injecting into the site. Here the site chosen is the iliac crest. He is injecting the local, then he is taking the needle and putting the needle into the iliac crest. After this, he is removing the stellate and putting the syringe and collecting the bone marrow tissue. And these cells are identified and they examined for the diagnostic purpose or treatment purpose. The next structure, we are going to see the epiphysis. Epi means upon, the physis we already known growth. The typical long bone presents two epiphyses at the ends. Usually it is ossified from the secondary center of the ossification after birth. They are cartilaginous. Epiphysis is filled with the spongy bones. We have seen the spongy bones consists of the rods and plates of bones. enclosing numerous spaces. They are filled with the red mora. Types of epiphysis is classified into pressure, traction, atavistic and aberrant epiphysis. If we take the pressure epiphysis first, it develops at the articulating ends where the formation of the joints take place. It facilitates the weight transfer. It is present at the ends of the bone. It is seen in the parts of the bone that is under pressure during the movements. The examples you know, head and condyles, head of the femur and the condyles of the femur, head, capitulum and trachea of the humerus, condyles of the tibia. Traction epiphysis, it is developed because of the pull of the muscle or muscles in non-articulating part of the long bone. You know the very well examples in the humerus, greater and lesser tubercles, in the femur, greater and lesser trochanter, mastoid process and medial and lateral condyles of the humerus also, example for the traction epiphysis. It provides attachment to the tendon and the muscles. In some bones where the pressure epiphysis and the traction epiphysis simultaneously develop, in this condition, usually the pressure epiphysis develops ossifies first, then that of the traction epiphysis. This atavistic epiphysis, in lower animals it is appears as a separate bone, but in the human skeleton, this portion of the bone fails to fuses with the nearest bone to, actually it fuses with the nearest bone to receive the nutrition from the host bone. It acts like a parasite. The example, coracoid process of the scapula and the posterior tubercle of the talus, also known as the os trigonum. Apparent epiphysis, this epiphysis usually develops in the unusual site of the short long bones. Now, usually the epiphyses are present at the base of this tarsal and the metatarsal and the metacarpal bones. But the epiphyses are if you take up the first metacarpal or metatarsal, usually it develops at the head. So it is called as aberrant epiphysis. Now, other type of classification of according to the number of the epiphyses, it is further classified in simple or compound epiphysis. The simple epiphysis, at the growing end of the long bone, more than one epiphysis may present. All these epiphyses joins with the through the epiphyseal plate to the metaphysis by a separate epiphyseal plate. Okay? If you take up the four, it contains the four epiphyses, meaning there are four joins with the diaphysis means of the four epiphyseal plates. It is called simple epiphysis, it is called upper end, the example upper end of the femur. In compound epiphysis, all the epiphyses joins with each other. Then it is fuses with the diaphysis by the epiphyseal plate, one epiphyseal plate. It is called compound epiphysis, example upper and lower end of the humerus. Now, the next presenting parts of the growing long bone, epiphyseal plate or growth plate. Why it is called growth plate? Actually, it is a plate of hyaline cartilage which intervenes between the diaphysis and the epiphysis of the growing long bone. It contains the numerous cartilaginous cells. The proliferation of the cartilaginous cells here is responsible for the growth of the length of the bone at the expense of the metaphysis. So, it persists up to which years? So, it persists up to the puberty, around 18 to 20 years. After the puberty, the epiphyseal cartilage is replaced by a bone and becomes epiphyseal line. The disorder of these epiphyseal plates may result in some disorders. Injury to the growth plate resulting in the shortening. Inflammation may result slight increase in the length of the bone. The metaphysis, the next structure is the metaphysis. It is the end of here. This is the metaphysis. It is the end of the diaphysis which appears close to the epiphyseal cartilage. It is the most actively growing area. It has the bone growth occurs in length at the expense of the metaphysis. Also, it is a highly vascular area. It provides attachment to the muscles, ligaments, all the structure. Now, we have seen after the puberty, epiphysis fuses with the diaphysis. Before this epiphyseal fusion, metaphysis is richly supplied by the end arteries and the arteries which forms the hairpin-like bends. You can be able to appreciate the hairpin-like bends. These are the end arteries. So, therefore, the infected material are commonly deposited here in the end arteries and these hairpin-like bends. So the metaphysis is common, the osteomyelitis of the bone commonly occurs in the metaphysis by this reason. After the epiphyseal fusion, what happens? The vascular connections are established between the epiphyseal and the metaphyseal arteries. So, as a result, the metaphysis contains no more end arteries in the adult. So, in adult, the osteomyelitis of the metaphysis is rare. Some situations, the metaphysis may be intracapsular. So, any disease of the joints may affect the metaphysis or vice versa. In Richards, you can be able to appreciate the cupping of the metaphysis. Periosteum. The next structure in the growing line bone, the periosteum. It is the outer covering of the bone. Peri means around. It is a fibrous membrane that lines the external surface of the bone except the where the bones are covered by the articular cartilage. At this place, where at the articular margin, the periosteum is connected to the capsule of the joint. It is made up of two layers. The outer layer, fibrous layer, the inner layer is an osteogenic cellular layer. This periosteum, here you can able to appreciate the periosteum. Now, it provides attachment to the ligaments and tendons. We have already seen the periosteum contains the collagen fibers. The collagen fibers of the periosteum are some tendons, the fibers of the some tendon pierce the outer surface of the bone, pierce the cortex of the bone, like spikes of the shoe. So thus bolting the periosteum to the bone tightly. So these spikes fibers are called Sharpie's fibers. The periosteum is usually supplied the abundant periosteal arteries. These periosteal arteries also supply the outer aspect of the combat bone. It is initially supplied with the nerve, most sensitive part of the bone. In sesamoid bone, this periosteum is absent. The function, protective osteogenic bone growth, it has a play role in the growth and the repair. The endosteum. Like the periosteum, this endosteum is a thin membrane that lines the outer surface of the marrow cavity or inner aspect of the combat bone. It also contains the osteoprogenitor cells. Now, coming to we have already seen the macroscopic classification. Coming to the next other types of classification. So each classification, we have the phylogenetic classification, morphologic classification, regional classification, developmental classification, structural classification, we are going to see one by one. If we take the phylogenetic classification, it is divided into the exoskeleton or endoskeleton. The exoskeleton, the remnants are present in the human beings as the nail or enamel to the teeth. In the lower animals, the exoskeleton is present as a form of the sheath over the body of the lower animals. The endoskeleton, all the bones of the bodies are called endoskeleton. Morphological classification, according to the shape, it is divided into long, short bones, flat bones, irregular bone, pneumatic bones, sesamoid bone, accessory bones. You know this classification very well. So, if you take up the long bones, further they are divided into typical long bones, miniature long bones, and the modified long bones. If we take up the typical long bones, it has the following features. 3 parts, the shaft and 2 ends. The shaft contains the medullary cavity. The outer surface of the shaft is filled by the compact bone. They always occupy in cartilage, lie vertically in the body. They are weight-bearing bones found in the limbs. They are humerus, example humerus radius ulnar, femur, tibia, and fibula. The miniature long bones, so the length is slightly shorter than the typical long bones. The examples are the metacarpal, metatarsal, and the phalangeal bones. Here they have the epiphyses at the one end only. So if you take up the ossification, all the metacarpals and the metatarsals have epiphyses at their heads except the first metacarpal, which have the metaphyses at their base. Modified long bones, the example for the modified long bones very well. The clavicle is the main example. The body of the vertebra is also the example. How will it differ from the why it is called modified long bones? It has some features of the long bones, not all the features. Some features are absent. Here they ossify in membrane. The long bones they ossify in cartilage. Here they ossify in membrane. It has no medullary cavity, but it has the functions of the long bone weight bearing. So it is called modified long bones. Now, the next short bones. Usually the short bones have the 6 surfaces, cuboid in shape. The example, carpal bones are tarsal bones. All the short bones ossify in cartilage after the birth, except the talus, calcaneum and cuboid, which starts ossification before the birth itself. The flat bones. If we take the flat bones, the outer and the inner wall of the flat bones consisting of the combat bone, the middle layer contains of the spongy bone. The intervening spongy tissues in the bones of the vault of the skull is known as the diplo. Most of the bones of the most of the bones of the vault of the skull, frontal, parietal, occipital, bones forming thoracic cage also for example for the flat bones. The irregular bones, the bones which do not fit into the above classification forms the irregular bones. Example, the bones forming the base of the skull, hip bone and vertebral bones. It also contains 2 layers of the combat bone and the middle layer of the spongy bone. The pneumatic bones you know very well. These pneumatic bones, it contains the air-filled spaces which are lined by the mucous membrane. They are confined in close proximity to the nasal cavity. The mucosa from the nasal cavity starts invading the neighboring cranial bones at the expense of this diploic tissue. So these air-filled cavities are called paranasal air sinuses. This pneumatization has the following functions. It makes the skull slightly lighter, add resonance to the voice. Also it acts as air conditioning chambers by adding the humidity and temperature to the inspired air. The sesamoid bones. Which one is the largest sesamoid bone in the body? Students, this is a question for you. Patella. What is the sesamoid bones? It is developed from the Arab word, the sesame, it means seed. They are seed-like bony nodules which develop in the muscles and the tendons of the bones which are subjected to the frequent friction. The sesamoid bones they act as a pulleys for the muscle contraction, changes the direction of the pull of the muscle, minimize the friction of the tendon. What are the main features of the sesamoid bones? Develop in the tendon, it is devoid of periosteum, is the main point. Only ossify after birth. There is a well-defined Haversian system are absent. It has no separate arterial supply. What are the common sites of the sesamoid bones? You know the patella very well. The fibula, it is developed in the lateral head of the gastrocnemius. Pisiform, you know, the tendon of the flexor carpi ulnaris. There are 2 sesamoid bones present below the head of the first metatarsal bone in the tendon of the flexor hallucis brevis. This is the example. Also one sesamoid bone in the tendon of the peroneus longus as it winds around the cuboid bone. Other sites, one sesamoid bone on the ulnar side of the head of the first metacarpal in the adductor pollicis. Another side in the radial side of the head of the metacarpal in the tendon of the flexor pollicis brevis. There is one sesamoid bone, rider's bone. It is the bone develops in the tendinous origin of the adductor longus in the lower leg. The last variety of the bones, morphological classification, accessory bones. They are generally not present. It may appear as a extras, they appear as a 2 ways. In first way, they appear as a extra center of the ossification in a bone and fail to unite with the main body mass. Example, sutural or Wormian bones of the skull and the interparietal bone. You can be able to appreciate here. In other forms of the accessory bones, non-fusion of the epiphysis. The epiphysis, it has a separate ossification center but it fails to unite with the main body mass. The examples are ars trigonum. Here the posterior tubercle of the talus may fail to unite with the rest of the bone. As Vessalinianum, the styloid process of the 5th metacarpal may fail to fuse with the rest of the bone. Patella cubitae, the ossification of the olecranon process starts separately and fails to fuse with the proximal end of the ulna. The regional classification is divided into axial and appendicular classification. Axial means in the center of the body, appendicular means the outside the central axis. Developmental classification, you know very well, the bones are developed from the intramembranous ossification, endochondral ossification. By this means they are divided into membranous bones or cartilaginous bones. Membranous bones develop from the membranous ossification. Cartilaginous bone develop with the cartilaginous or endochondral ossification. The examples for the membranous bone, cranial vault and facial bones. For the cartilaginous bones, the limbs, bones of the limbs, bones of the base of the skull and the thoracic cage. Some bones develop in both type of ossification. They are called membranocartilaginous bones. Main examples are mandible, clavicle, occipital, temporal bone and sphenoidal bone. So there is another one developmental classification. Visceral bones and somatic bones. The visceral bones are developed from the pharyngeal arches. Okay. So they are example for the development of hyoid bone, part of the mandible, air ossicles. All the other bones are called somatic bones. Now, the main important thing, the macroscopic structural classification. Macroscopic and microscopic classification. The macroscopic classification, we have already seen this classification. It consists of a compact bone and a collagenous or spongy bone. Here is the structure is a ivory-like with no space. Here is it has the more number of rods and plates of bones with the enclosing spaces giving the spongy appearance. The microscopic classification, it is divided into 4 types. Woven bone, lamellar bone, dendin and cementum. First, the woven bone or primary bone or immature bone. Here, the collagen fascicles and the bone crystals, they are arranged randomly, resembling the woven fabric. So, where it appears? It appears in the embryonic lobe, all the developing bones. First, initially, all the bones are formed like a woven bone only, immature bone. And it is also present in the repair of the fracture of the bones. Then, the microscopic, the next bone is the lamellar bone or secondary bone or mature bone. Here, the bones are arranged in layers, lamellae. Here there is a central canal, it is arranged in the lamellae. The lamellae are arranged in 2 patterns. Here is this one pattern. Concentric cylindrical units around the eversion canal. It is the example of the compact bone. In spongy bone, it appears as a branching and anastomotic plates. All the adult bones are the lamellar bones. The dentin and cementum, the remnants, this dentin is the example for the 4 main components of the tooth. The cementum is the calcified substance covering the root of the bone. Now, this is the main thing. So, according to the microscopic structure of this lamellar bone or mature bone, you have seen in the histology classes. This is a repetition only. The basic microscopic structure of any bone of adult. It consists of, you can able to appreciate the diagram, it consists of many layers. So it is made up of layers. It's a basic structure of any bone of this adult. Consists of many layers. Each lamellae, the layers are called lamellae. Each lamellae is thin plate of bone consisting of the collagen fibers and the mineral salt that are deposited in the gelatinous ground substance. This bone consists of the gelatinous ground substance, salts and the collagenous fibers. Now, the spaces between the 2 lamellae are called lacunae. The lacunae contains the osteocytes. The adjoining lacunae are interconnected by the canaliculae. You can be able to appreciate the radiating canaliculae here. Okay? The canaliculae are occupied by the cytoplasmic process of the osteocytes. The collagen fibers of the one lamellae is parallel to each other. But the collagen fibers of the adjoining lamellae are run varying angles to each other, but usually at right angles. But the ground substance of the lamellae is continuous with the adjoining lamellae. So the main lamellae, between the lamellae, lacunae contains osteocytes. The osteocytes, the lacunae are connected by the canaliculae. Canaliculae contains the cytoplasmic process of the osteocytes. Now, so this is the microscope. We have seen the basic structure of any bone. Now we see the microscopic structure of the compact bone. It consists of also the lamellae. Here the lamellae are arranged around the arranged as a concentric rings around the canal called Haversian canal. This is a Haversian canal. The Haversian canals run parallel to the long axis of the body, long axis of the bone. It contains the blood vessel, nerve fibers, and the loose connective tissue. In between the lamellae, you have the lacunae, the same thing. Lacunae communicate with one another with the central canal, or also with the central canal or medullary cavity by the numerous radiating canaliculae. These canaliculae contain the cytoplasmic process of the osteocytes. These canaliculae act as a pathway for the nutrients and oxygen to the osteocytes. Continuation of this microscopic structure. Now, if you take the one Haversian canal and the surrounding, the concentric layers are collectively called as Haversian system or osteon. It is a structural and functional unit of the bone. It is roughly about each Haversian system or each osteon of the 150 micrometer in diameter. Number of lamellae in each osteon is the 4 to 10, average is 6. About 21 millions of the osteons are estimated to be present in the adult human body. Now, the adjoining lamellae are separated. This is one lamellae, this is another lamellae. They are separated from each other by means of the cement line. What is the cement line? It contains only the mineral salts and no collagen fibers. Now, these Haversian canals communicate with each other and with the medullary cavity, with the outer surface by means of the horizontal or obliquely running canals called the Workman's canal. This is a Haversian canal. They are interconnected by means of the Workman's canal. Also, this Haversian canal connected to the medullary cavity by means of the Workman's canal. Also, this is to the external surface by means of the Workman's canal. So, blood vessels from the periosteum or endosteum enter the bone through the Workman's canal. The Haversian, okay. Now, so far we have seen the circumferential lamellae situated around the Haversian canal. Now, if you take the other types of lamellae present in the microscopic structure of the combat bone, interstitial lamellae, you are able to appreciate the numerous osteons or Haversian system, one Haversian canal and concentric layers. In between these osteons, there is a spaces. These spaces are occupied by the interstitial lamellae. What is this interstitial lamellae? They are nothing but the remnants of the osteons which are destroyed by the osteoclasts during the growth and remodeling of the bone. The other types of lamellae, apart from the circumferential, there is a well-developed Haversian system and this, there are called circumferential lamellae. What is the circumferential? There are two types, external circumferential lamellae and the inner circumferential lamellae. The external circumferential lamellae here, you can be able to appreciate. It lies just the inner to the periosteum. The inner circumferential layer lies outside the endosteum, around the Mara cavity. So both these lamellae are not concentric. They are parallel to the surface. Now, according to the concentration of the mineral salts and collagen fibers, these lamellae are divided into cementing lamellae or fibrillary lamellae. In the cementing, they are rich in minerals and less in collagen fibers. In fibrillary, they are rich in collagen fibers, less in mineral. Now, so far we have seen the microscopic structure of the combat bone. Now we will see the microscopic structure of the spongy bone. Now, here the trabeculae of the spongy bone consists of superimposed lamellae. In the lamellae, in the combat bone, we have seen the regularly arranged concentric layers of the lamellae. Here, they are superimposed lamellae in the spongy bone. They do not form the Haversian system. Okay, so you can say the trabeculae are lamellated without the Haversian system. There is a layer of osteoblasts on the surface of this lamellae, trabeculae. Now, if we take these trabeculae, lamellated trabeculae are oriented along the lines of stress. What is this law? It depends upon this trabeculated lamellae. According to this law, Wolff's law, bone formation, this osteogenesis is directly proportional to the stress and strain. But usually, the compressive forces favors the bone resorption. The tension forces favors the bone form. This is the law. The law states that the tensile forces favors the bone formation, whereas the compressive forces favors the bone resorption. But this theory, however, no longer holds good because both tensile and compressive forces nowadays stimulate the bone formation in the appropriate conditions. According to the Wolff's law, the architecture of the cancellous bone, the lamellae, they are called the pressure lamellae and the tensor lamellae. What is the pressure lamellae? According to the Wolff's law, the pressure lamellae are arranged parallel to the line of weight transmission. You can able to see the pressure lamellae. The tensor lamellae right angles to the pressure lamellae. One special type of the pressure lamellae is the calcar femoral. You can able to see in the femur. Here the pressure lamellae are arranged in the compact manner, extending from the neck to the lesser trochanter. Now. What is the reason for the pain and the fracture site at the lateral leg? Sometimes you can suffer the fracture. The fracture is healed well. After that also you have some pains in the fracture site. What is the anatomical reason? This is the reason. The trabeculae, usually they are oriented along the line of the stress within the bone according to the Wolff's law. After the fracture healing, the direction of the weight bearing may change slightly. Also, the newly formed trabeculae realigns with the new line of stress. The weight bearing direction change, the line of stress change. So the new bones, they realign with the new line of stress. Okay? It takes some time to realign. So this is the reason for the pain in the fracture site after the long period of time. Now, on the lateral side, why I have been chosen as a speaker in this here? There is a reason for the fracture. There is another reason for choosing. Only one reason for both your professor and associate professor chosen. What is the reason? Next slide explains. Yes. Here, this is a gentleman, G.S. Sokumar. This gentleman, Velayadam, is a cardiologist here, urologist. They are my classmates. They are 87 batchmates. You know very well. Okay? So, you know very well. So, this is the reason. So, in the microscopic structure, we have seen this bone composed of the various cells. The cells of the bones, there are 4 types of osteoprogenital cells, blastocytes and osteoclasts. First, we see the osteoprogenital cells. They are pluripotent stem cells derived from the mesenchyme. It resembles fibroblasts. Differentiated into the osteoblasts whenever the growth of the bone is required. In fetus, they are numerous at the sites of the bone formation. In adult, they are present over the bone surfaces only, on the periosteum and the endosteum only. The osteoblasts, they are the bone forming cells. They are derived from the osteoprogenitor cells. Okay? They are precursor cells of the osteocytes. They are derived from the osteoprogenitor cells. They are precursors of the osteocytes. They are found lining the growing surface of the bone. They have the various shape, triangular, oval or cuboidal, contain the oval euchromatic nuclei, basophilic cytoplasm because of the abundance of the rough endoplasmic reticulum. It has the well-developed Golgi complex. Osteoblasts are responsible for the laying down of the organic matrix and the collagenous fibers. So they are bone forming cells. So according to the name, they are responsible for the laying down of the organic matrix and the collagen fibers. They are also responsible for the calcification of the bone. Alkaline phosphate, they secrete the alkaline phosphate which is responsible for the calcification. So it has these numerous matrix vesicles. Now, usually in every bone, the salts are present in the form of the hydroxyapatite crystals. So these osteoblasts secrete the matrix vesicles. These matrix vesicles are responsible for the formation of the hydroxyapatite crystals. They undergo mitosis. Osteocytes. Now, they are the mature bone cells. Okay? So, mature bone cells, they are nothing but the osteoblasts which are imprisoned within the matrix during the bone formation. The osteoblasts are converted to the osteocytes during the process of this bone formation. They are flattened cells with numerous cytoplasmic processes containing the elongated heterochromatic nucleus, containing the less amount of the rough endoplasmic reticulum, so it produces the eosinophilic cytoplasm. These cells have the cytoplasmic process. They are responsible for the maintenance and the remodeling of the matrix. We have already seen these osteocytes lie in the lacunae. The average lifespan of each osteocyte is about 25 years. Osteoblasts, they are bone removing cells. They are multinucleated, large multinucleated cells, each having average 50 nuclei, 20 to 100 nanometer diameter. The cytoplasm shows the numerous mitochondria, lysosome, which contain the acid phosphorus, which are responsible for the destruction of the bones. It is found in relation to the surfaces. Where the osteoclasts are present, you can able to appreciate here. Where it lies in the surface, it has a small depression. Okay? This depressed area is called lacunae of Ausips or resorption base. Now, on the surface of the osteoclast, which lies in contact with the bone, it has numerous infolding. These infoldings are called a ruffled border. The main function is the bone removal. It is done by the steps involve the demineralization of the and the removal of the cartilage. Demineralization mainly done by the osteoclast. So they are derived from the fusion of the mononuclear phagocytic system, as in we have already seen. They are like that of the giant cells of the macrophages. Now, the parathyroid hormone or the calcium play a role in the osteoclast. Parathyroid hormone stimulates the osteoclast. So the projection of the ruffled border increases. Increased bone resorption, so increase in the blood calcium level. Opposite, calcitonin depresses the activity of the osteoclast. The ruffled border becomes less, decreased bone resorption, decrease in the blood calcium level. Now, so far we have seen the classification, what is bone functions, the classification, macroscopic structure, microscopic structures. Now, moving on to the arterial supply of the bones. We have to see first, we will take up the long bones, typical long bones, the arterial supply. It is supplied by the 4 types of artery: nutrient artery, metaphyseal artery, epiphyseal artery, periosteal artery. This arterial supply of the long bone is a frequently asked university question. It was asked about 4 or 5 times in the university examination. The 3 years back also it was asked as a 5-mark question. Arterial supply of the long bone. It is supplied by the nutrient. First we will take up the nutrient artery. The nutrient, it enters through the middle, roughly, usually in the middle of the shaft through the nutrient foramen. Usually, before entering, it forms it is tortuous. Okay? So, this tortuosity is responsible for the least affected during the movements of the bone. It runs obliquely, like here in the picture, usually it is, here in the picture it shows like a horizontal, but usually oblique in the cortex to reach the medullary cavity, where it ends by dividing into the ascending branch and the descending branch. This ascending branch and the descending branch divides into a number of smaller branches, which branch forms the hairpin-like loops at the metaphyses. The loops anastomoses with the periosteal arteries and the metaphyseal arteries. So the metaphysis is the most vascular area of the long bone. Nutrient artery supplies the medullary cavity and the inner 2/3 of the cortex of the bone, of the diaphysis and the metaphysis. The oblique direction of the nutrient foramen in the shaft is opposite to the growing end of the bone. The number of the nutrient arteries vary, several in femur and 1 in tibia. You know very well the nutrient artery of the tibia is the largest nutrient artery of the body. If you take up the metaphyseal arteries supplying the long bones, these metaphyseal arteries, you can able to appreciate, they are derived from the neighboring arteries, enters the metaphysis beyond the articular caps. Epiphyseal arteries, epiphyseal arteries, they are derived from the arterial anastomosis around the joint. Now, here there are two types, the epiphyseal arteries. In bones, where the articular cartilage is connected with the epiphyseal cartilage, epiphyseal plates, in the example in the head of the femur, the epiphyseal artery initially pierces the epiphyseal plate and supply the epiphysis. Suppose if it is so, these bones are vulnerable to the injury. Suppose if the bones are injured at the epiphyseal plate, there is epiphyseal separation occurs, resulting in the avascular necrosis. Now, in bones where the articular cartilage are not continuous with the epiphyseal plates, so these epiphyseal arteries enter directly into the these ends of the bone supplies. So they are not vulnerable to the avascular necrosis. Coming to the last artery supplying the long bone, periosteal arteries, they are branches of the adjacent muscular arteries. They are numerous, supply the periosteum. The supply enter the bone through the Waxman canal to supply the outer one-third of the compact bone. We have seen the arterial supply of the long bone. If you take up the short long bones, it is supplied by the nutrient artery, but here, once it enters the inferior artery enters the shaft, it divides into form the plexus immediately. It is also supplied the epiphyseal and metaphyseal like that of the long bones. Now, the osteomyelitis, you know, it is the infection of the bone, it is common in children. If you take up the typical growing long bone, the infection occurs in the metaphyseal region. We have already seen this reason because the metaphyseal region is richly supplied by a rich blood supply, supplied by the end artery which form the hairpin-like bend. So bacteria and emboli are easily trapped here. So in growing long bone, osteomyelitis begins in the middle of the shaft. In the long bone, the metaphysis is the common site for the osteomyelitis. But in the short long bone, it begins in the middle of the shaft. Why? Because the nutrient artery enters the shaft and immediately form the plexus. The emboli are trapped in the plexus. Flat bones, you know, it is supplied with the nutrient artery periosteal like that of the long bones. If you take up the vertebra, so some set of the branches, they pierces the posterior aspect of the body. Some set branches the anterolateral surface of the body. One branch pierces the root of this transverse process. The venous drainage. In cancellous bones, it has the humerus venous plexus, example vertebra. In compact bone, they accompany the arteries in the Waxman canals and Everstein canals. Lymphatic drainage. The bone do not have the well-defined lymphatics. But anyhow, the numerous lymph vessels are you can able to appreciate in the periosteum. They drain into the regional lymph nodes. Nerve supply. The nerve accompanying the blood vessels through the Waxman canal or Everstein canal, they are usually autonomous, sympathetic or parasympathetic. So some of the sensory branches usually supply these periosteum and the ends of the bones. Coming to the main thing, ossification. So far we have seen the structure of the bone. Coming to the ossification, it is the two types of ossification we have already seen. First we will take up the intramembranous ossification. Listen. The mesenchymal tissue of the mesenchymal tissue are condensed to form the membranous sheet. The mesenchymal cells, they are fibroblasts. You can able to see the mesenchymal cells. They become tensely packed and differentiate into the osteoblast. These mesenchymal cells differentiate into the osteoblast. Okay. The site where these changes are occurring is called ossification centers. Continuation of the intramembranous ossification. You can able to appreciate here. Carefully see this diagram. The osteoblast now secrete the ground substance and the collagen fibers to form the osteoid tissue. This is called osteoid tissue. It contains the collagen fibers and the ground substance. So under the influence of the alkali phosphatase, the osteoid tissue is mineralized. After the formation of the osteoid, it is mineralized by means of the alkaline phosphatase secreted by the osteoblast. Now this osteoid becomes converted into the one lamella of the bone, one layer of the bone. Okay. Over this lamellae, the second layer of the osteon is formed. Now, the osteoblasts move away from this site and line this newly formed osteoid. Now, this second layer of the osteoid is again mineralized to form the second layer of the bone. The third layer of the osteoid is formed. In this way, the number of lamellae are laid down over the another. So, the newly formed trabeculae are arranged in irregular form to form the woven bone. Whatever the bone form, both of the bones, it is initially woven bone. Continuous deposition of the lamellae and the trabeculae converts into the compact bone. Now, the second type of ossification, cartilaginous or endochondral ossification. Now, most of the bones ossify in cartilages. Now, it is the endochondral ossification. First, there is a formation of the cartilaginous model in the this cartilaginous ossification. Cartilaginous model of the long bone consisting of the inside you have seen you can be able to appreciate the numerous hyaline cartilaginous cells. Cartilaginous model is formed consisting of the hyaline cartilage which are differentiated from the mesenchyme of the limb. The mesenchyme of the limb differentiated into this cartilaginous model. This model is surrounded by a layer called perichondrium. Now, next stage is the formation of the primary areola. Now, the cartilaginous model, we have seen the cartilaginous model, it grows in length by the interstitial method, grows in width by the oppositional method. Cartilaginous cells, they are cartilaginous cells, they are arranged from end to the middle of the shaft, middle of the cartilaginous model as a following rows, longitudinal rows. You can be able to first zone of proliferation, they are proliferated by mitosis. Zone of maturation, the cartilaginous cells enlarge, the mature cells secrete the chondroitin sulfate, that is the cartilaginous matrix. Zone of hypertrophy and zone of calcification, then the hypertrophic cells secrete the alkaline phosphatase which calcifies the matrix. Proliferation first, then maturation. The maturation here, chondroitin sulfate is secreted, then hypertrophy, here alkaline phosphate calcifies the matrix. Then zone of calcification. So after the calcification, the cartilaginous cells are cut off from the nutrition. So immediately after this, the death of the cells leaving the spaces called primary areolae. Okay, the cells become dead and they leaving the spaces. The primary areolae is not shown here. The primary areolae are formed in the mixed section of the model. Now, at the same stage, there is a formation of the periosteal collarbone. So, simultaneously, the perichondrium develops osteogenic potential. Perichondrium is vascularized. These chondrogenic cells in the perichondrium differentiate into the osteoprogenitor cells. These osteoprogenitor cells differentiate into the osteoblasts. At this stage, the perichondrium is transformed into the periosteum. The osteoblasts lay down the layer of the bone underneath the periosteum to form the periosteal bone collar. You can be able to appreciate the periosteal bone collar. Now, formation of the primary center of the ossification. Now, the calcified cartilage, the osteogenic layers of the periosteum forms the periosteal bud. You can be able to see the periosteal bud. This periosteal bud contains of the blood vessels, osteoclast and osteoblast. The periosteal bud excavates through the wall of the bone, through the cortex of the bone, developing cartilaginous model of the. So it reaches the primary areolae. It destroys the walls of the primary areolae by means of the decalcification. Okay? So the walls of the primary areolae, adjoining primary fuses with each other to form the secondary areolae. Now, the secondary areolae are filled with the bone, filled with the more marrow cells. The outer surface of these secondary areola lined by the osteoblast. The same thing. The osteoblast secretes the one layer of the osteon, then it converted into the osteoid, then a newly formed layer, then second layer of the osteon, then third layer of the osteon. All these, like this, numerous layers of the bones are formed within the developing cartilaginous model. So, here, the central part of the cartilaginous model, we have seen the cartilaginous model, the central part of the cartilaginous model, where these changes are taking place are called primary center of ossification. During remodeling of the bone, so we have seen inside the medullary cavities, during the developing bones, there are many various bone spicules are present. The bone spicules are removed by the osteoclast, forming the well-defined perimedullary cavity. Simultaneously, new bones are deposited beneath the periosteum to form the compact bone. The ossification extends in the longitudinal direction from the middle of the shaft. Now, so we have seen the primary center of the ossification. Now the formation of the secondary center of the ossification. After the birth, one or more secondary centers appear at the ends of the cartilage, forming the epiphyses. We have seen the primary center of ossification forming the diaphyses. Now the epiphysis, the secondary center forms the diaphyses, the epiphyses. So here in the secondary center, also the same process of the formation of the maturation cells, all these things take place. Okay, the same process of the ossification is repeated here as in primary center to form these epiphyses. Now, you have already seen epiphyseal plate of cartilage separates the developing diaphyses with that of the developing epiphyses. The epiphyseal cartilage and the articular cartilage remain cartilaginous. The epiphyseal plates of cartilage continue to producing new cartilage cells responsible for the bone growth in the length. For these reasons, the epiphyseal plate of cartilage is called growth plate. Once the bone attains its entire longitudinal length, the epiphyseal cartilage is replaced by a bone, leaving behind a scar called the epiphyseal line. So this is we have seen the membranous ossification and the cartilaginous ossification. Coming to the ossification center, the ossification centers are nothing but the sites where the bone formation begins. Ossification begins around the 8th week of intrauterine life and is completed by the 25 years. There are two ossification centers, primary and secondary ossification center. Primary center of ossification usually appears roughly in the middle of the developing bone model, usually at the age of 6 to 8 weeks of the intrauterine life. Some exceptions. The primary centers for the tarsal and the carpal bones appears after birth, except those of the talus, calcaneum and cuboid. Secondary center of ossification forms the epiphyses. As a rule, they appear after birth only, from birth to the 5 years, except the lower end of the femur. Here appears as a rule after the birth, from the birth to 5 years, except the lower end of the femur and the upper end of the tibia, where this ossification center appears in the 9th month of intrauterine life itself. This is the two X-rays are viewed. The X-ray of the newborn. Kindly they go through this X-ray. See which one is the term, which one is the preterm. Just now I have told the lower end, except at the secondary center ossify after the birth, appear after the birth, except the lower end of the femur, upper end of the tibia. Have you seen any ossification center here? There is no. But here you can able to appreciate the ossification center, secondary ossification center. So whenever you see the X-ray of the newborn, secondary ossification center, but it is term, it is a preterm. The fusion. The fusion of the epiphyses with the diaphyses starts at the puberty, usually completed by the fusion. Okay, epiphyseal place with that of the diaphysis completed by the age of 25. is a rule. Ossification begins earlier in females than in males. Fusion of the epiphysis with the diaphysis completed 2 to 3 years earlier in females than males. Because of this, the females always have slight lesser in this, slightly shortened length. The law of union of the epiphysis, law of epiphysis. Now, this law states epiphyseal center which appears first unites lots with the diaphysis. Epiphyseal center which appears late unites first. Whenever you say any law, when you produce law, somebody has to violate the law. Here the violating bone is the fibula. Okay? In fibula, epiphyseal center for the lower end appears first. Here the epiphyseal center appears first for the lower end. It effuses with around the age of 15 to 17 years. Here the epiphyseal centers for the upper end appears late and unites late. It violates the law of ossification. So growing end of the long bone, you know, the end where the secondary center appears first and unites last with the diaphysis indicates the growing end of the long bone. The growing end always lies opposite to the direction of the nutrient foramen. The direction of the nutrient foramen of the long bone can be remembered by the following dictum. To the elbow I go, from the knee I flee. Okay, this is the direction of the nutrient foramen. Therefore, in the upper extremity, the shoulder end and the wrist ends of the bones are the growing ends. In the lower extremity, lower end of the femur and the upper end of the fibula and the tibia are the growing ends. So, this is the chronology of the primary prenatal ossification center before the birth. I'm not going to the detail. Second. Postnatal development of the bones. First, second, you can able the years. Okay. So these development, the age at which end of the bone develops, they find place in the numerous applications. Mainly, the deciding the age. Forensic medicine, it has a greater role. It's a chronology of postnatal development, continuation of this. Thank you. Thank you, my dear students. So, we have seen what is bone. Composition of the bones. What are the classification of the bones? Basic, all the classification we have seen in detail. All the microscopic structure of the bones we have seen. Types of the microscopic structure of all the bones we have seen. We have seen just the ossification center. The remaining process of the growth of the bone, remodeling, all these things will be highlighted by your professor. Thank you, Pa.
Thank you, sir. Your insights today have not only expanded our academic horizons, but have provided us with a renewed sense of purpose.
We extend a cordial welcome to Dr. S. Sadasivam sir, Professor and Head of Forensic Medicine, Government Medical College, Dindigul. Dr. Kamaraj sir, Associate Professor of General Medicine, Government Medical College, Dindigul. Dr. Surya Kumar sir, Associate Professor of Microbiology, Government Medical College, Dindigul. Dr. B. Jayapriya ma'am, Professor and Head of Pathology, Government Medical College, Dindigul. Dr. P. V. Balamurugan sir, Professor of General Medicine, Government Rajaji Hospital, Madurai. On the behalf of Department of Anatomy, Government Medical College, Dindigul, we extend a warm welcome. Welcome, sir and ma'am.
Good morning, everyone. First of all, I would like to thank Faculty of Anatomy Department for offering this opportunity. It's my great pleasure to invite you, sir, for this CEP OSTEOPREV 2026. We are very much honored to have you with us here today, sir. The topic you presented, dynamic ostium, bone formation and dynamics, were very thorough and insightful. videos and PowerPoint slides are very clear and informative. Thank you, sir, for such an inspiring session. Myself also learn a lot from your lecture. I hope really our students are also enjoy your session. Thank you for sharing your expertise. So, thank you.
Thank you, madam. Actually, this is the first time I am presenting with the PPT. I always used to take the class board and chalk only. Nowadays, in all the medical colleges, they are having well-developed lecture class with this PowerPoint presentation. There is no blackboard. In many medical colleges also same. I personally bought blackboard for me. I used to take the classes with the board and chalk only.
I now kindly request our HOD ma'am, Dr. Jayarani, to honor our speaker. Thank you, ma'am. I now kindly request Dr. Sadasivan sir and Dr. Kamaraj sir to felicitate our esteemed chairpersons in this session. I now kindly request Dr. Sadasivan sir and Dr. Kamaraj sir to felicitate our esteemed chairpersons of this session.
Transitioning from function to fundamental origins, we now turn our gaze towards the primordial stages of skeletal development. We shall traverse the complex embryological pathways that dictate how our framework is born into existence. We extend a cordial welcome to Dr. Jayarani Ma'am, Professor and Head of Anatomy, Government Medical College, Dindigul, a scholar of anatomical precision, to lead this exploration. We are
our anatomy department to given these opportunities. I am going to introduce our speaker, Dr. Jayarani Madam. Madam is a professor and HOD of Anatomy. Madam has 25 years government service, 17 years teaching experience. Madam finished his undergraduate in Madurai Medical College 92 batch, and post-graduation DGO from Kilpauk Medical College 2005 batch, and MS Anatomy in Madurai Medical 2007 batch, and ACME Jipper 23 batch. Thank you, Madam. You have to start your session.
Happy morning to all of you. Very good. Are you ready to join with me for your journey of embryonic development of bone? Are you ready? Start your embryonic development of bone. Yes? Yes, okay. So let us see. Please follow my words, okay? Yes. So please close your eyes and take deep breath and be clear? So where your bone gets started? From the intra-embryonic mesoderm. From there we can have a axial skeleton and appendicular skeleton and the membranous bone formation. So everything it was discussed by our previous speakers. Yes. Then we can have these classification. Next. So what are the things we are going to see here? We are going to see the malformation, then maturity evaluation, then maintenance of the growth, then morbidity assessment, then medico-legal aspects, okay? So this is we have discussed. So all the time you have open your eyes and think of your bone development. This is classification based on the ossification, okay? That's also dealt clearly by our previous speaker. So we can have how many ossification? What are the classification based on the ossification? Intramembranous classification, ossification, then endochondral ossifications, okay? Yes. So these going to develop the cartilage forming bone and the membranous forming bone. So our bone formation is compared with the building of the building built, okay? So by laying the matrix with the mineralization, then bone formation in the membranous part, but in the endocardial part we are intervening with the cartilaginous model, okay? So remodeling is nothing but a fusion of the bones and attaining the primordial model that's going to attain in the adult. So what is your age now? 7th week, okay? So your mom want to screen you for the first trimester anomaly scan, okay? What do you mean by the first trimester? Tri means 3. So first 3 months of pregnancy is known as the first trimester. So she wants to rule out the some anomaly in the first trimester. She wants to have a consultation with the radiologist, and she is attending the radiology department, and that radiologist or sonologist nicely picks your nasal bone. So he is informed that your baby is okay. We can able to see the beautiful nasal bone. Okay. Then your mom become very happy. You are also very happy, isn't it? Yes. Okay. Then come to out of the way. You have to come out. Okay. Then see this picture. What is the difference between these two pictures? Here you can able to see some structure, isn't it? But it is not present here. Can you able to catch it? So that indicates absence of nasal bone. So this is related to some genetic disorder, mostly Down syndrome, about 70%. Okay? Yes. Then சினிமாவில் வர மாதிரி சில மாதங்களுக்கு பிறகு ஓகேயா, அப்போது நம்மளுக்கு 4 வாரத்துக்கு பிறகு, ஸோ ஆஃப்டர் 4 weeks ஆஃப் பீரியட், then what is your age now? 7 + 4? நாங்கள் மேக்ஸில் ரொம்ப வீக் மேடம், அதனால தான் மெடிசனே வந்தோம். நீங்கள் திரும்பியும் 7க்கும் 4க்கும் கணக்கு கேட்குறீங்க. எஸ், ஓகே. ஸோ நவ் யுவர் ஏஜ் இஸ் 11th week, where we have seen the nasal bone. Okay. Again கொஞ்ச நாளைக்கு அப்புறம், சரியா, சில மாதங்களுக்கு பிறகு சினிமாவில் வரும்ல அதே மாதிரி. Okay. So again after 4 weeks of period, then what is your age now? 11 + 4? 15. வெரி குட் மேடம். நாங்கள் மேக்ஸ்லலாம் ரொம்ப வீக்கு கிடையாது. நாங்கள் வேணான்னு ஐடி வேணான்னு மெடிசனுக்கு வந்திருக்கோம், அப்படி தானே? எஸ், ஓகே. ஸோ again during 15th week, your mom wants to rule out the second trimester anomaly scan. Then she attended again the same sonologist and requested them to look for the bone development. Okay. Then he has traced the very beautiful line in the vertebral spine. Okay, and he has informed that your baby is okay. Now you are in second trimester, isn't it? 15 weeks, and he is telling that your baby is okay. Again, that mom is very happy. Okay, and you are also doing some hic movement in the uterus. Okay, by hearing this. Okay, then come out and see this picture. Can you see difference? Can you able to see some bubbles like sign, isn't it? Something. Okay, so this is due to the failure of fusion of the spinal part, that is posterior neural arch. Okay, that is appear as a spina bifida. Okay, so this spinal deformity may be associated with the neural tube defects. Okay, neural tube defects. Okay, yes. So come to the point. மேடம் டெவலப்மெண்ட் பேசுகிறேன்னு சொல்லிட்டு ரேடியாலஜியை பேசிகிட்டு இருக்காங்களே. ஸோ பை நோயிங் தி பீரியட் ஆஃப் ஃபார்மேஷன் ஆஃப் ஸ்ட்ரக்சர் அண்ட் தி ப்ரெசன்ஸ் ஆஃப் ஸ்ட்ரக்சர், அதானே, அதான் நம்மளுக்கு நேசல் போன் இருக்குன்னு சொல்லிட்டாங்க. அதே மாதிரி நம்மளோட ஸ்பைனல் டெவலப்மெண்ட்டும் இருக்குன்னு சொன்னதுனால we are happy. Then to assess the period of development இந்த 11வது வாரத்தில் nasal bone இருக்கணுங்கிறது develop ஆயிருக்கணுங்கிறது நம்மளுக்கு தெரிஞ்சிருக்கணும், isn't it? That is the embryological knowledge, okay? அதே மாதிரி spinal development clear-ஆக இருக்கணுங்கிறது நம்மளுக்கு செகண்ட் ட்ரைமஸ்டரில் தெரிஞ்சுருக்கணும். That is the embryological knowledge, okay? So to know the period of formation of the structure and the presence of the structure, இருக்க வேண்டிய ஸ்ட்ரக்சரும் இருக்கணும், இல்லாமல் போனாலும் அது developmental anomaly, okay? எக்ஸஸாக இருந்தாலும் அது developmental anomaly, okay? So to assess all those things and confirm the formation and to rule out the malformation, we should have a developmental knowledge, okay? Yes. What is your inference here? தெரியல. இப்போ நம்ம எந்த வாரத்தில் இருந்தோம்? 15வது வாரத்தில் இருந்தோம், okay? Then the days is passing on. Then your mom wants to see you in the world, okay? But she is very scared about your maturity. So she wants to confirm your maturity, okay? Because that preterm will causes the respiratory problem to the newborn, isn't it? So she want to deliver in a term status, okay? Then she have consulted with the radiologist to confirm the maturity, okay? Yes. Who is she? யாருடா அது? சினிமா ஆக்ட்ரஸ் போட்டிருந்தா நேரம் தெரிஞ்சிருக்கும். சிஎம்இனால நான் போடக்கூடாதுன்னு போடலை, ஸ்ட்ரிக்டாக. அப்பா யாரோ சொல்கிறாங்க, பசங்க சொல்கிறாங்க, எப்படி உங்களுக்கு மட்டும் தெரிஞ்சிச்சுன்னு கேர்ள்ஸ் எல்லாம் திரும்பி பார்க்குறாங்க. ஒருவேளை மாற்றி போட்டிருந்தா தெரிஞ்சிருக்குமோ இப்போ கேர்ள்ஸுக்கு, ஓகே? ஸோ திஸ் இஸ் தி லோயர் எண்ட் ஆஃப் த femur, okay? So this shows the secondary ossification center. That means the baby attained the maturity at the age of 9th month of intrauterine life, okay? So if that we can able to see the lower end of the epiphysis with a secondary ossification center in the femur, so we can assess the fetal age is the 9th month or just before birth, okay? Now what is your age? So your femur is, we can able to see that sonologist confirm the secondary ossification center in your lower end of the femur, okay? Then what is your age now? 9th month, okay? So your mom planned for the delivery and expecting the beautiful days, okay? This is the question I want to frame, okay? டைட்டிலும் சேர்ந்து வந்துருச்சு. எஸ். So what is the inference here? So appearance of the secondary ossification center of the endochondral ossification implies the maturity of the bone, so that indicates the 9th month of the fetal age, okay? Here I want to share the facts. The only secondary center, sir already discussed everything. The only secondary center appear in the intrauterine life is the lower end of the femur, okay? Like that we can have all the time, we can have the exception. The primary center usually appears in the intrauterine life, but for corpal bone it appears after birth, 1 per year from the 1st year to the 7th year, okay? So this is the fact. So like that, when we see the anatomical positions of both hands from the anterior surface, we can have the appearance of the corpal bones. For the right hand, it is anti-clockwise direction. For the left hand, it is the clockwise direction, both from the ulnar side, okay? So these things implies the gives an idea for the development of the ossification center and knowing the knowledge of the development of the bone, okay? இப்போ நம்ம வெளியில் வந்துட்டோமா? இந்த வேர்டில் தான் இருக்கும். எஸ், ஓகே, எஸ். இதில் என்ன டிஃபரன்ஸ்? ஹவு டு இன்டர்பிரட் த பிக்சர்? சரி, வெளியில் வந்துட்டீங்க, அப்புறம் கொஞ்சம் பெருசாகிட்டோம், நம்ம ஸ்கூலுக்கு போகணும், ப்ரைமரி ஸ்கூலுக்கு போவோமா? ப்ரைமரி ஸ்கூல் முடிச்சதுக்கப்புறம் எங்கே போவோம்? ஹையர் செகண்டரி ஸ்கூலுக்கு போவோம். இட்ஸ் நாட் ஒர்க்கிங் த. என்ன டிஃப்ரென்ஸ் இதில்? ப்ரைமரி ஸ்கூலுக்கு போகிறப்ப நீங்கள் எப்படி இருப்பீங்க? குட்டியாக அழகாக இருப்பேன் மேடம். இப்போ தான் படித்து நீட்டுக்கு ரெடியாகி நான் ஐ ஹவ் லாஸ்ட் எவ்ரி திங் அந்த மாதிரி சொல்கிறீங்களா? ஓ, செகண்டரி ஸ்கூல், ஹையர் செகண்டரி ஸ்கூலுக்கு போகிறப்ப யூ வில் பி வெரி க்ரோன் அப் சைல்டு, isn't it? ஓகே, ஸோ வாட் இஸ் தட் மெயின் டிஃபரன்ஸ்? அடையாளமே தெரியாத மாதிரி மாறிடுவீங்க சிலவங்கெல்லாம். சிலவங்களுக்கு மட்டும் அந்த குட்டி அழகாக இருந்த முகம் இருந்துக்கிட்டே இருக்கும், அதெல்லாம் கிஃப்டடு. சிலவங்களுக்கு பிடிக்கும், சிலவங்களுக்கு பிடிக்காது. சிலவங்களுக்கு அம்மா மாதிரி இருந்தால் பிடிக்கும், சிலவங்களுக்கு அப்பா மாதிரி இருந்தால் பிடிக்கும். உங்களுக்கெல்லாம் யார் மாதிரி இருந்தால் பிடிக்கும்? ஆக்ட்ரஸ் பேரை சொல்லிடாதீங்க தயவுசெய்து, மனசில் நினச்சாலும் சொல்லக்கூடாது. எஸ், ஓகே. ஸோ we can find the difference. They are attained the maturity, isn't it? Okay, so they have attained the growth in a height. So how will you assess the height, which is the responsible for the height? Again the secondary ossification center in the lower end of the long bones forms a epiphysis. It increases the size and shape of the epiphysis and ultimately fuse with the growth plate. Okay, so till now வந்து இப்போ நம்ம சிலவங்கலாம் வந்து அந்த ஷார்ட் ஸ்டேச்சராகவே இருப்பாங்க. ஒரு பீரியடுக்கு வந்ததுக்கப்புறம், இப்போ காலேஜுக்கெலாம் வந்ததுக்கப்புறம் என்னோடய ஃப்ரெண்டோட பொண்ணு கேட்டாப்புல, ஆண்டி நான் வளர்ந்துருவேனா, எனக்கு சந்தேகமாக இருக்குது அப்படின்னு கேட்டாங்க. நான் சொன்னேன், ஏன்டா இவ்வளோ சந்தேகப்படுறேன்? இல்லை, நான் சின்ன பிள்ளையாக இருக்கிறப்ப எங்கள் மம்மி எனக்கு காம்ப்ளான் தரலையா அப்படின்னாங்க. ஸோ வெதர் ஷி இஸ் ரியலி ஆஸ்கிங் தட் ஐ டோன்ட் நோ. ஸோ அதனால் நம்ம காம்ப்ளான் குடிக்கலைனாலும் நம்ம வந்து வளருவோமா மாட்டோமா அப்படிங்கிறது நம்மளுக்கு தெரியணும். ஆல் ஆஃப் யூ அக்ரி வித் மீ? எஸ், ஓகே. அப்போது எந்த வயசு வரைக்கும் வில் கெட் அ growth, that is around the 25 years of our age. ஓகே, அது வரைக்கும் நம்மளுக்கு growth இருக்கும் with a sparing normal epiphysis. ஓகே, அது நார்மலாக இருக்கணும், இன்ஜுரி எதுவும் ஆயிடக்கூடாது. ஓகேயா? எஸ். ஸோ இப்போ நம்ம எங்கே இருக்கோம்? ஹையர் செகண்டரி ஸ்கூலுக்கு போயிட்டோம், சரிங்களா? ஓகே, சரி. இப்போது how many of you have experienced with the injury of the bone? Please raise your hand. இந்த வெள்ளையாக ஒரு மாவு கட்டு போட்டாங்கன்னு சொல்லுவாங்க, அப்போல்லாம் நம்மளுக்கு பேர் தெரியாது. எஸ், someone wants to raise the hand. பரவாயில்லடா, இப்போ எல்லாம் நார்மல் ஆகிட்டீங்க, அப்படி தானே? ப்ளீஸ் ரைஸ் யுவர் ஹேண்ட். கண்டிப்பாக வீரத்தெலும்பு வாங்காமல் இருந்திருக்க மாட்டோம். கேர்ள்ஸ் இல்லைனாலும் பசங்க. நோ ஒன்னா? யாருக்கெல்லாம் சைக்கிள் ஓட தெரியும்? அதுலேயும் கொஞ்சமாக தான் தூக்குறீங்க. நாங்கள் நேராக ஸ்ட்ரெயிட்டு வந்து 2 வீலர் பைக் அல்லது கார் தான் மேடம். சைக்கிள் ஓட்டிருந்தா கண்டிப்பாக கீழே விழுந்திருப்பீங்க. நிறைய பேருக்கு நான் கேள்விப்பட்டிருக்கேன், மெடிக்கல் காலேஜ்லேயும் சைக்கிள் ஓட்ட தெரியாதான், சரியா? ஸோ சைக்கிள் ஓட்டிருந்தீங்கன்னா கண்டிப்பாக கீழே விழுந்திருப்பீங்க. ஸோ உங்களுக்கு கண்டிப்பாக என்ன பண்ணியிருப்பாங்க, பெரிய சர்ஜரிலாம் பண்ணியிருக்க மாட்டாங்க. ஓகேயா? இப்போ எல்லாருமே ஹேல் அண்ட் ஹெல்த்தியாக வித் மூவிங் ஆல் யுவர் லிம்ஸ், isn't it? சரி, how many of you have underwent for the surgery with plates and screw? நம்ம கடையில் பார்க்குறது, மெக்கானிக்கல் ஷாப்பில் பார்க்குறதெல்லாம் உள்ளே வச்சு தச்சிருப்பாங்க. அந்த மாதிரி யாரும் இங்கே இருக்கீங்களா? அந்த அளவுக்குலாம் நாங்கள் இல்லை மேடம். நாங்கள் வந்து எங்களுக்கு வந்து ரிஸ்கெல்லாம் ரஸ்க் சாப்பிட்ற மாதிரி. ஸோ நோ ஒன் அண்டர்வென்ட், இஃப் யூ ஆர் வெரி ட்ரூ, no one underwent for the surgery with the plate and screw. Am I correct or not? So everyone is active. So what I want to implicate this, வரல, நீ பண்றியா? So what is your inference with the experience of the fracture? வீட்டில் யாரும் பெரியவங்க இருக்காங்களா? அவங்களுக்கு அடிபட்டிருக்கா? அவங்களுக்கு ஆப்ரேஷன் பண்ணியிருக்காங்களா? பண்ணியிருக்காங்களா பாட்டி தாத்தாவுக்கு? ஆப்ரேஷன் பண்ணி எந்திரிச்சு நடந்துட்டாங்களா? ஜேபி மேடமோட பாட்டி underwent the hip replacement, I think, with trochanteric fracture with plates and screw. ஓகேயா? எஸ், அதனால் அவங்க வருத்தப்பட்டு சொல்கிறாங்க, பாட்டிக்கெல்லாம் அடிபட்டால் எப்படி மேடம் எந்திரிச்சு நடக்கிறது அப்படின்னு. ஓகேயா? ஸோ தட் இண்டிகேட்ஸ் தி children are always continue growing. That is the message I want to deliver. Children are C for continue growing, but adult means attain the growth. Okay? So this makes the injury remodeling and the healing effect. Okay? So this point I want to stress, which hinders the growth. அதனால தான் நான் சொல்கிறப்ப சொன்னேன், everyone will continue our growth till 25 years of age, ஆனால் with sparing of our epiphyses of our long bones. Okay? So அது ரொம்ப முக்கியம். ஸோ எல்டர் பீப்புளெலாம் இருந்தாங்கன்னா அவங்களுக்கு இன்ஜுரி ஆச்சுன்னு சொன்னால் அவங்களோட ரீமாடலிங்லாம் நம்மளுக்கு அவ்வளோ சரியாக இருக்காது. அதனால் அவங்களுடைய ரெக்கவரி வந்து நம்மளுக்கு ரொம்ப லேட்டாக இருக்கும். ப்ளஸ் அவங்களுடைய இன்ஜுரியே ரொம்ப காம்ப்ளிகேட்டடாக இருக்கும். ஸோ ஓகே, ஸோ ஐ வாண்ட் டு correlate the growth spurt or maintenance of the growth and the injury to the epiphyses. Okay? Now, second. Again, pertaining to this part, what is your inference? முகலாம் பார்த்தா நல்லா பெரிய ஆள் மாதிரி இருக்குது, ஆனால் வளர்ச்சி மட்டும்தான் இருக்கிற மாதிரி தெரியல. ஓகே, எனி ஐடியா? நீனே பண்ணுமா? இவருக்கு எதுவும் அடிபட்டிருக்க மாதிரி தெரியுதா? அப்படி இல்லை. ஸோ தேர் இஸ் அ disproportionate growth. Can you able to see the disproportionate growth, isn't it? Okay, then what is the name for that? Achondroplasia. Okay, so chondro means cartilaginous. Okay, so A means absence. Okay, so here absence of the cartilage model formations. Okay, because of that they are very dwarf, and here there is a no chondro means cartilage, so no chondral endochondral ossification. They have a short arm and the legs. So can you see this word? Rhizomelic. So short term and the short arm and the legs. Okay, so you may expect further your NEET PG. Okay, yes. Then the question is here, achondroplasia due to, just guess it. Chocolate irukka? Chocolate. Just guess it. என்ன மேடம் கொடுக்க போகிறீங்க? நாங்கள் வேற எதுக்கு கெஸ் பண்ணி எங்கள் டைம் எல்லாம் வேஸ்ட் பண்ணணும்? எனி கெஸ்? எதையாவது சொல்லுங்கடா. ஒன்றுமே தோணலையா? ஒன்றுமே தெரியலன்னா தெரியலன்னு கூட சொல்லுங்கள் சத்தமா. தெரியல மேடம். ஓகே, ஸோ டியூ டு ஜெனட்டிக் டிஸார்டர். ஓகே, எஸ். மோஸ்ட் ஆஃப் த டைம் எம்ப்ரியாலஜி வந்து அடல்ட்டில் வந்து அனாமலி இருந்துச்சு, டிஃப்ரென்சியேஷன் இருந்துச்சுன்னா ரொம்ப ஈஸியாக வைவால் ஈவன் ஃபார் ஃபைனல் இயர்ஸ் all the time ஒய்ன்னு தான் கேட்பாங்க. ஸோ யூ கேன் போர்ட்லி சே தட் டெவலப்மெண்டல் அனாமலி. ஓகே, நம்ம கிராஸில் இருந்து எம்ப்ரியாலஜி படித்தோம்னா நம்மளுக்கு ஈஸியாக இருக்கும். ஆனால் எம்ப்ரியாலஜிலேருந்து கிராஸ் படிக்கிறப்ப மண்டை காஞ்சு போயிடும். ஓகேயா? ஸோ அதனால் யூ ஹேவ் டு அப்ளை தி கிராஸ், why it has happened like that, then you can apply the embryology over it. Okay, so all the time ஒரு ஆன்சர் தெரியலன்னா you can 50% you will be correct. You can boldly say that it's a embryological problem. Okay, சரி, அதே மாதிரி எம்ப்ரியாலஜியில் வந்து நாங்கள் எதுவும் டவுட் கேட்டோம்னா you can straight away say that most of the things due to genetic disorder. Okay, this one are the clue for you. Osteoporosis என்ன? அதுதான் நம்மளோட சிஎம்இ டாப்பிக்கே. ஆஸ்டியோபோரோசிஸ்னா என்ன? போனெல்லாம் வீக் ஆகி நம்மளால் நடக்க முடியாமல் போகும் வயசானா. சரியா மேடம்? நீங்கள் வயசானா சொல்கிறீங்க, இப்போயே எங்களுக்கு அப்படி தான் இருக்குது. நீங்கள் உட்கார விடலைன்னா எங்களுக்கு கஷ்டமாக இருக்குது. டிசெக்ஷன் ஹாலில் 3 மணி நேரம் நிற்க வச்சிங்கன்னா எங்களால் முடியலை. ஓகே, ஸோ ஆஸ்டியோபோரோசிஸ் காமன் இன் ஏஜ்டு பீப்புள். பட் ஆனால் குழந்தைக்கு ஆஸ்டியோபோரோசிஸ் வருமா? வந்துருச்சு. ஓகே, அது எதனால? திஸ் டியூ டு அகெயின் ஆஸ்டியோஜெனிசிஸ் imperfecta. So by the means itself, osteona enna bone formation, genesis na bone formation, imperfect, அதனுடைய formation வந்து imperfect இருக்கு. Okay, so here the osteoid stimulation is less. அதுதான் வந்து I want to deliver the message. So here you can see the osteoporosis in the newborn or the very childhood period. So it is also known as the brittle bone disease, and with the because they are more fragile, easy for the fracture. Okay, yes. So one of you, can you able to read? First bone to ossify in our body na ninga சொல்லிருவீங்கல. first use சொல்ல மாட்டீங்களா? first bone to get ossify in our body clavicle. ஆனா அந்த क्वेश्चन போடல, கொஞ்சம் யோசனை பண்ணலாம்னு. கார்பல் போன்ல. வெரி குட், சூப்பர். யார் பதில் சொன்னா? சூப்பர் சூப்பர். எந்திரிடா. என்னடா வச்சிருக்க? சாக்லேட் இருக்கா, அல்வா இருக்கா, ஏதாவது ஒன்று கொடு. சார் கொண்டு வந்து கொடுத்தாருல, கொடு, எடுத்துட்டு வா. எந்த பேட்ச்டா? ஸ்ரீதர்ஷினியா? வெரி குட், சூப்பர். ஸோ வி கேன் கிவ் குட் அப்ளாஸ் டு ஹர். வெரி குட். இன்னும் அனாட்டமி ஞாபகம் வச்சிருக்க. தேங்க்யூ. என்னடா, ஏதாவது கொடுங்கடா. எந்திரிச்சு வேற நிற்க சொல்லிட்டேன். உங்களுக்கு வச்சிருந்த அல்வா கூட கொடுங்க, அப்புறமேல் நான் வாங்கி தரேன். எஸ், வாடா. செகண்ட் கொஸ்டின், நம்பர் ஆஃப் போன்ஸ் இன் நியூ பார்ன். உங்களோட ஹைட் என்னன்னு தெரியுமா நீங்கள் பிறந்தப்போ? சார் பீடியாட்ரிஷியன், தப்பாக சொன்ன என்ன திட்டிடுவார். அவ்வளோ குட்டியாக இருக்கிறப்போ, 50 சென்டிமீட்டர் இருக்கிறப்போ நம்மளுக்கு வந்து எவ்வளோ போன்ஸ் இருக்குது? நம்ம நினச்சிக்கிறோம் ரொம்ப ஹைட்டாக பெருசான பிறகு தான் நிறையா போன் இருக்குன்னு. ஆனால் இல்லை. சரியா? சார் படிச்சிருக்கீங்க. தேங்க்யூ தேங்க்யூ தேங்க்யூ. சூப்பர். ஸோ நியூ பார்ன் போன் நம்பர் நெட்டில் பார்த்தாச்சு. எஸ், சூப்பர், வெரி குட். ஓகே, அடல்ட்டு அது நீட் கொஸ்டின் மேடம். ஓகே, லாஸ்ட் போன் டு கம்ப்ளீட் இட்ஸ் ஆசிஃபிகேஷன் இன் அவர் பாடி. அப்பா, சூப்பர். ஸோ வாட் இஸ் யுவர் இன்ஃப்ளூயன்ஸ் ஹியர்? ஒரு ஓல்டு லேடி கீழே விழுந்திருக்காங்க, பக்கத்தில் அவங்க எக்ஸ்ரே. இந்த சைடில் போன் இருக்குது, இந்த சைடு ரீப்ளேஸ்மெண்ட் இருக்குது. ஓகே, ஸோ அப்போ ஓல்டு ஏஜில் எப்படி இருக்கும்? ஆல்வேஸ் சிவியர் அண்ட் நீட் தி இன்டர்வென்ஷன், மோஸ்ட்லி சர்ஜிக்கல். ஸோ reasoning out, fracture in children, faster healing, which is 2 to 3 times faster. Reasoning out, childrenல அடிபட்டா ஹீலிங் வேகமாயிருமா? அதுக்கு தான்டா அந்த கொஸ்டின் கேட்டேன். ஆகும் ஆனால் ஆகாது அப்படிங்கிறீங்களா? எஸ். போன் ஆசிஃபிகேஷன் seen in the fracture site, sesamoid bone. What is sesamoid bone? பிள்ளைங்க மார்க் கம்மியாக வாங்கினா யூனிவர்சிட்டி டிபார்ட்மெண்ட்டை கேட்கும். டிபார்ட்மெண்ட்டில் ஸ்டூடெண்ட் சரியாக சொல்லலைன்னா டிசெக்ஷன் ஹாலில் சரியாக சொல்லித்தரலன்னு அட்மினிஸ்ட்ரேட்டர் கேட்போம் நாங்கள். சொல்லிடா, வாட் இஸ் செசமாய்ட் போன்? லிம்ஸ் எல்லாம் முடிஞ்சு 2 மாதம் மேலே ஆச்சு மேடம். நாங்கள் இப்போ அப்டமனில் பெல்விஸில் நிற்கிறோம். நீங்கள் அதில் ஏதாவது கேளுங்க, ஞாபகம் இருக்கான்னு பார்க்குறோம். கேன் யூ ஏபிள் டு see? So children, that severity of the injury is less. With increased blood supply, that healing is more. Okay, it's a true one. Then answer for the second question, sesamoid bone is a bone appearing in other than the where it's a tendon, isn't it? Okay, it's not a pathological one. that heterotrophic ossification only, we can see the bone formations. Okay? Yes. So, fracture healing. If they, இந்த இதுக்கு தான் நான் கொஸ்டின் கேட்டேன். நீங்களாம் வந்து நிறைய இன்ஜுரி ஆயிருப்பீங்க. அது வெறும் பிளாஸ்டர் ஆஃப் பாரிஸ் பிஓபி மட்டும் போட்டு நம்மளுக்கு வந்து ஹீலிங் நடந்துருந்துச்சுன்னா அங்கே வந்து எண்டோகாண்ட்ரல் ஆசிஃபிகேஷன் நடந்திருக்கும். ஓகேயா? நீங்கள் பிளேட் அண்ட் ஸ்க்ரூலாம் போட்டு உள்ளே குத்தி விட்டிங்கன்னா அதில் வந்து நம்மளுக்கு என்ன இருக்கும்? இன்ட்ரா மெம்பர்னஸ் ஆசிஃபிகேஷன் இருக்கும். ஸோ த ஹீலிங் இன்ஜுரி இஸ் அ மேஜர் ரோல் ஃபார் தி morbidity and the outcome. Okay? Next. This is a mnemonic for that finalists or the NEET PG. So, as I said earlier, children is the continue growing, adult is the attained growth. So, because of the collagenous nature, the children have a more flexible and the less injury, and the healing is quickly. Always need the conservative management, mostly. Okay? Then, because of increased growth and blood supply, the healing is better. So, less occurrence of the severity, that is comminuted fracture or the complex fracture. Disability and deformity is less common. Remodeling is present, that is most important. Because of this, we can overcome the injury morbidity. Then early mobilization is possible. இது ரொம்ப முக்கியம். ஏன்னா we have to resume our routine duty. இப்போ நீங்களாம் வந்து நிறைய தடவை சம்டைம்ஸ் எங்கிட்ட வந்து ஃப்ராக்சர் ஆயிடுச்சு, எங்களுக்கு ஒன்றுமே தெரியாது, நீங்கள் என்ன பண்ணிட்டு போவீங்க? மேடம் 2 மாதம் எங்களை ரெஸ்ட் எடுக்க சொல்லியிருக்காங்க ஆர்த்தோ டாக்டர். We are also doctor. Okay, so we know the normal development and the healing and all. So for the lower limb, it is may extend up to 4 to 6 weeks only. Okay, அதனால நீங்கள் வந்து அந்த 1.5 மாதத்துக்கு மேலெல்லாம் எக்ஸ்டெண்டே பண்ண முடியாது. Okay, so we should have a knowledge about this development. Okay, so for the upper limb, the 4 weeks is enough for the healing. So here, the no need of external fixation, that is the surgical intervention less இருக்கும். Adultல பார்த்தீங்கன்னு சொன்னா again adaptation is less, that is they will have a more morbidity with the deformity and disability is common. JP madam ரொம்ப சஃபர் ஆகிட்டு இருக்காங்க, அவங்க பாட்டி வேகமாக ரெக்கவர் ஆகணும்னு. ஸோ this is the reason for that. And union of the bone is the mostly non-union or the malunion. அதனால தான் நம்ம எத்தனை பேர் அடிபட்டாலும் நம்ம என்ன பண்ணியிருக்கோம், நம்மளுக்கு அந்த எந்த ஒரு எவிடன்ஸே இல்லாமல் we are moving actively, isn't it? அதை தான் நீங்கள் ஃபஸ்ட்டு சொன்னீங்க. It's a reflection from your side only. Then there is a longer rehabilitation needed. அதாவது மோஸ்ட் சப்போர்ட் they are needed. எல்டர்லி பீப்புளுங்கிறதுனா நிறைய பேர் எல்லோரும் வெளியூரில் போய் செட்டில் ஆயிடுவீங்க. ஸோ அதுவே நம்மளுக்கு வந்து சப்போர்ட் இல்லாமல் இருக்கிறதுனால that rehabilitation is extending. Then there is a treatment is mostly surgical, and compared to children the remodeling is not possible. Next. So last but not the least, we have to utilize this developmental knowledge for the medical legal aspects. Forensics are இங்க இருக்காரு, நான் நிறைய பேச முடியாது. So I want to deliver the 3 points. Age determinations, mostly in the juvenile crime. Okay, then gender difference identification, and females usually 1 to 2 years early recovery. Then evaluation site, we have to look for elbow, wrist and the hand. Next. So pick the false statement related to the growth plate. So growth plate is between the end of the diaphysis and the epiphysis. It has a endochondral ossification occurs in the growth plate related to elongation of the long bones. Then intramembranous ossification. Which one is false? Fourth. Very good. எனக்கு கொஞ்சம் தான் கேட்டுச்சு, இருந்தாலும் நானே சப்போர்ட் பண்ணிக்கிறேன், ஏன்னா தப்பாக வந்துச்சுன்னா ரொம்ப கஷ்டமாக இருக்கும் எனக்கு. So self-assessment, the answer is 4. So conclusion, we have bond with the bone, feet with a beat, and be with a good imagine technique also. Then hope and hope with the healing. Have a happy, healthy bone or boon. Okay? Yes, thank you all.
Thank you, ma'am. We are profoundly grateful for the time and expertise you have dedicated to ensure that the foundation of OSTEOPREV 2026 is built on excellence. We extend a warm welcome to Dr. Ram Prabhakar Sir, Associate Professor of Community Medicine, Government Medical College, Dindigul. Dr. M.D.D.M Sir, Assistant Professor of Community Medicine, Government Medical College, Dindigul. Dr. Hema Mali Ma'am, Assistant Professor of Physiology, Government Medical College, Dindigul. Dr. Lata Ma'am, Associate Professor of Biochemistry, Government Medical College, Dindigul. Dr.S.R.Veeramani Sir, Deputy Superintendent, Government Medical College, Dindigul. Dr. Muthukavitha Ma'am, Associate Professor of Pharmacology. Dr. Malalviri Ma'am, Assistant Professor of Biochemistry, Government Medical College, Dindigul. Dr. Shenbaga Devi Ma'am, Assistant Professor of Physiology, Government Medical College, Dindigul. Dr. Bhaskar Sir, Professor and Head of Physiology, Government Medical College, Dindigul. Dr. Abhirami Ma'am, Assistant Professor of Physiology, Government Medical College, Dindigul. On the behalf of Department of Anatomy, Government Medical College, Dindigul, we extend a warm welcome.
So, distinguished speakers, esteemed colleagues and faculties, and my dear students. So, it is a great privilege and honor to me to chair this session titled Genesis Ostium. So, first in the topic பார்த்தப்ப Genesis Ostium பார்த்தப்ப சரி ஏதோ some boring-ஆன subject-ஆ இருக்கும் அப்படிங்கிற மாதிரி நினச்சேன். ஆனால் மேடம் இருந்துக்கிட்டு நிறையா ஸ்லைட்ஸ் போட்டு ரொம்ப இன்ட்ராக்டிவாக இருந்துக்கிட்டு இந்த செஷனை இருந்துக்கிட்டு கேரி அவுட் பண்ணியிருக்காங்க. ஸோ அந்த எம்ப்ரியாலஜி மட்டும் இல்லாமல் ஃபாரன்சிக்கு, அதே மாதிரி ஆர்த்தோபெடிக்ஸ், ட்ரமட்டாலஜி, ரேடியாலஜி, ஓஜி, பீடியாட்ரிக்ஸ் எல்லாமே அங்கங்கே டச் பண்ணி இந்த செஷனை இருந்துட்டு லைவாக நல்லா ஒரு லைவ்லியாக கொண்டு போயிருக்காங்க. தி செஷன் வாஸ் very neat and tidy like her. Okay, so forensic aspect la irundhu paakrappa mad already kadasila touch panna madri, the bones are not the silent structures, they are the repositories of truth. ஒரு டெட் பாடி இருந்துக்கிட்டு எவ்வளோ எவிடன்ஸ் இருந்துக்கிட்டு சொல்லுதோ அதே அளவுக்கு a skeleton will also tell tales, otherwise stories. Okay, so அதனால் you must have the forensic knowledge to hear the voices raised by the skeleton. So the forensic osteology plays an important role in the identification of, that is in the mass disaster identification of the victims. ஒரு scene of crimeல இருந்து நிறையா skeleton கிடைக்கிறப்ப whether the bones are belonging to the same individual or to different individual அப்படிங்கிறத நம்ம அசஸ் பண்ண தெரியணும். அதே மாதிரி the race of the individual, ஒரு skull bone வச்சு நம்ம சொல்லலாம். The age of the person can be determined. Similarly, the sex of the person can be determined. ஒரு entire skeleton இருந்துச்சு அப்படின்னா 100% accuracy-யோட நம்ம இருந்துகிட்டு செக்ஸை டிட்டர்மைன் பண்ணலாம். பெல்விஸ் அண்ட் ஸ்கல் மட்டும் இருந்துச்சுன்னா போதும் 98% அக்யூரேசியோட ஒரு செக்ஸ் டிட்டர்மினேஷன் சொல்லலாம். அதே மாதிரி பெல்விஸ் மட்டும் இருந்தால் போதும் 95% அக்யூரேசி கிடைக்கும். அதே மாதிரி எனி லாங் போன்ஸ் இருந்துச்சுன்னா 80% ஆஃப் அக்யூரேசியோட செக்ஸ் வந்து டிட்டர்மைன் பண்ணலாம். அதோடு இருந்துக்கிட்டு காஸ் ஆஃப் டெத் கேன் பி டிட்டர்மைன்ட் பை அப்சர்விங் தி போன். ஃபார் எக்ஸாம்பிள் எனி ஃப்ராக்சர் சஸ்டைன்ட் ஆயிருந்துச்சு அப்படின்னா that might be an antemortem fracture which might be the cause of death. அதே மாதிரி டைப் ஆஃப் ஃப்ராக்சரை வச்சு கைண்ட் ஆஃப் வெப்பன் யூஸ்னே நம்ம சொல்லலாம். ஒரு கட் ஃப்ராக்சர் இருந்துச்சு அப்படின்னா ஒரு ஷார்ப் வெப்பன், ஒரு மல்டிபிள் ஃப்ராக்மெண்ட்ஸாக ஆயிருந்துச்சு அப்படின்னா ஒரு பிளண்ட் ஃபோர்ஸ். சிமிலர்லி ஒரு ஃப்ராக்சர் ஏலா சிக்னேச்சர்னு சொல்லுவோம். ஒரு சுத்தியல் வச்சு அடிக்கிறப்ப அந்த சுத்தியோட முனி இருந்துக்கிட்டு அந்த ரவுண்டாக இருந்துட்டு ப்ரொடியூஸ் பண்ணும் ஒரு ஸ்கல்லில். ஸோ அதை ஃப்ராக்சர் எல்லாம் சிக்னேச்சர் சொல்லுது, தட் இஸ் கால் சிக்னேச்சர் ஃப்ராக்சர். ஸோ அந்த மாதிரி தி டைப் ஆஃப் ஃப்ராக்சரை வச்சு நீங்கள் கைண்ட் ஆஃப் வெப்பனை வந்துட்டு யூஸ் பண்ணலாம், சொல்ல முடியும். ஸோ அந்தளவுக்கு மோர் ஃபாரன்சிக் இம்பார்ட்டன்ஸ் வந்துக்கிட்டு bones வச்சு இருக்கு. Not only in the dead, but also in the living. By looking at the appearance and fusion of the ossification centers by visualizing the X-ray, you can say the age of the individual. It is medically more significant. ஒரு மைனரா மேஜரானு டிஸ்டிங்விஷ் பண்ணுறத எக்ஸ்ரே ஆஃப் தி எல்போ ரிஸ்ட் வச்சு இருந்து நம்ம வந்துட்டு சொல்ல முடியும். ஸோ இந்த மாதிரி இந்த ஃபொரன்சிக் இம்பார்ட்டன்ஸ் வந்துட்டு இது போன்ஸ் வச்சு ரொம்ப ரொம்ப இம்பார்ட்டன்ட். அதாவது போன் ஃபார்மேஷன்லேருந்து இட்ஸ் டிஸ்ட்ரக்ஷன் அண்ட் கம்ப்ளீட் டீகேயிங் வரைக்கும் எல்லா ஸ்டேஜ்லேயுமே இருந்துட்டு போன்ஸ் ஆர் கிவிங் வெரி குட் சயின்டிஃபிக் இன்ஃபர்மேஷன் ரிகார்டிங் தி காஸ் ஆஃப் டெத். ஸோ thank you very much, madam, for your nice presentation. I congratulate the entire team for the nice organization, and I wish the CME a grand success. Thank you.
Madam, your slides are very wonderful actually, but you covered from the first MBBS to final year, whole MBBS or osteology related curriculum you covered, madam. But then you, the way of explanation also very easily understand for the students. It's a very good slides. I really congratulations to you for your excellent and wonderful presentation, madam. Thank you, madam.
On the behalf of Department of Anatomy, Government Medical College Dindigul, we extend our warm welcome to Dr. Uma Maheshwari Ma'am, Assistant Professor of Biochemistry, Dr. Shrek Sir, Assistant Professor of Forensic Medicine, Government Medical College Dindigul, and Dr. Manikandan Sir, Associate Professor of Forensic Medicine, Government Medical College Dindigul. I now kindly request Dr. B.R.J. Kannan Sir to honor our speaker. And also I welcome Dr. Parthiban Sir to honor our speaker. I now kindly request Dr. SureshBabu Sir, Dr. Jayapri Ma'am, and Dr. Surya Kumar Sir to felicitate our esteemed chairpersons of this session.
Beyond mere structural support, the skeleton serves as a metabolic reservoir, maintaining a vital bond with the body's systemic homeostasis. This session seeks to unravel the biochemical nuances that govern bone turnover and mineral consistency. We are profoundly grateful to have Dr. B.R.J. Kannan Sir, Director of Cardiology, Vadamalayana Hospital, Madurai, to grace the stage with his interdisciplinary insights. To facilitate this intellectual exchange, we warmly welcome our chairpersons, Dr. T.SureshBabu Sir, Pediatric Surgeon, Dr. B. Jayapriya Ma'am, HOD and Professor of Pharmacology, and Dr. Surya Kumar Sir, Associate Professor of Microbiology, GMC Dindigul.
Actually, introduction to the B.R.J. Kannan is junior to 4-year junior to me. Actually, we missed one eminent cardiologist at government setup. Is in private setup, very eminent cardiologist and good Tamil poet. Tamil romba kavithai எழுதிருக்காரு actually. தமிழில் கவிதை எழுதியிருக்காரு. good cardiologist actually. Actually, the topic, actually it means basically, first introduction to the topic, this interaction between the cardiovascular system, his system and bone metabolism. You should know after the completion of CME program, you should know what you mean osteoblast, what is glastic activity, you should know, and some of the terms, inner osteodystrophy and chronic kidney disease, how it affect the bone and rickets, some of the topic terms you should know of the same completion CME, okay. Basically, what is simplify, actually the calcium will dislodge from bone and lodge in the heart and main vessels. Result the calcification of the vessel. That is cause ischemia of vascular ischemia, vascular calcification. That is the main problem. Most of the kidney disease, chronic kidney disease, not die due to kidney disease. It die due to cardiac cause, vascular cause. That's the basic. There's a basic you should know. The chronic kidney disease not die of kidney disease, but due to vascular calcification. Result
deficiency in the body, the supplements will come out in the urine or they will cause side effects. Okay. So more importantly, whenever you say his joint is very strong, not that his bone is very strong. Yes, the bone is very strong, but what made the bone very strong? Muscles. So the more you move, more you train your muscle, you make your bone much more healthier, and that's going to give you a very wealthy life in the future. So this is example number one. So I had a neighbor, I cannot take the name, and he was looking very hale and healthy, 48 years old. One fine day in the bathroom, he just slipped and he had a fracture. How can a 45-year-old gentleman can have a fracture by slipping at the bathroom? See what happens, there should be some other secondary reason which can weaken the bone. So that's the today's topic, osteoporosis. He was an asthmatic, and he found that whenever he takes steroids, his asthma gets recovered. So without proper consultation, without proper inhalatory treatment, he was taking oral steroids now and then for the past some 5 to 6 years. And he was getting rid of his asthma. Externally he was looking okay, but internally that chronic steroid usage cause osteoporosis and cause fracture. So all these are very clinically relevant. So today's topic is basically to prevent the osteoporosis and then how to prevent the osteoporosis as once it occurs, how to treat. The details are going to come in the next lecture. So my slides are going to be very limited slides. It's going to be a revision of what you have seen in the previous 2 lectures. Okay, I'll go very slow. Let us just understand what is happening in the bone, and it's going to be a revision, I can just tell you. So as everybody has been telling, bone is not a stone. Okay, so it's an organ that is constantly changing. Okay, doesn't show up there. So bone is a dynamic organ. It has multiple functions. It has structural support function. It's a calcium phosphate reservoir. It does hematopoiesis. It also has endocrine functions. It produces osteocalcin, FGF23, and hence it influences cognitive functions and male fertility. In order to perform these diverse functions, bone undergoes continuous cycles of modeling and remodeling. So we do know that bone has outer bone, which is called cortex, which does the mechanical function of low transmission, liver action, everything. Whereas the inner bone, which is a cancellous bone, which causes a biological function. Because of its honeycomb nature, there is a very high surface area. So this again exemplified by a femur, where you transect the femur, you see this kind of outer bone and inner bone. But still, the compact bone is very strong. Because the compact bone is very strong, this is taking the load of the body. But see here, in the vertebra, it's mainly cancellous bone. Okay, so spine is very important. Our spinous process is very important for us to remain straight. But it's many times, it's cancellous. That is the reason why, in older individuals, you hear about spine fracture very commonly. Of course, the femur fracture is occurring, but spine fracture is very common. And if further zoom this picture of this cancellous bone, what do you see? This is what you see. So there are a lot of empty spaces in the bone. There are a lot of other structures are there, but a lot of empty bones are there. Okay. See, when Dr. Parthiban highlighted this fact, like in a child less than 1 year, the entire body is producing hematopoiesis, or the bone of the entire body is functional. Okay, it has mainly red bone marrow. But when the child grows into an adult, the red bone marrow is limited to the central portion of the body, whereas all the peripheral limbs become more of a yellow bone marrow or a strong bone marrow, aiding for movements and the other functions of the bone. Okay, so the biological functions of the bone, basically because of in the form of hematopoietic cells, it produces RBCs, WBCs, and platelets. There is progressive differentiation, maturation, and entering the circulation. See, as high as 2.5 billion red blood cells and platelets, and 50,000 billion granulocytes are produced per day. And then a equal number is destructed per day. So it's a constant continuous cycle. The continuous cycle is done by the bone marrow. It's a very important biological function of the bone. So what are the other metabolic functions of the bone? It stores minerals. It is a reservoir of calcium and phosphorus. Whenever there is a deficiency in the serum calcium, it is the bone which gives the calcium. Once the serum calcium is replenited, that goes into the bone and gets deposited. So it's a storage house for calcium and phosphorus. It stores growth factors, insulin-like growth factor, transformation growth factor, bone morphogenetic proteins, and others. They're all stored in the bone. It also stores fat. But of course, this fat is not in big number, but it also has a small element of storage of fat. Is that all? It also has further actions. What does it do? It maintains the acid-base balance. It buffers the blood against excessive pH change. Okay. So what is the normal pH of the blood? It is 7.4. Our normal pH is alkaline. You know, 7 is the neutral pH, but 7.4 is alkaline. But our normal pH is, our body is predominantly alkaline. Except in stomach, most of the places we have alkaline pH. So it buffers the blood against the excess pH changes by absorbing and releasing alkaline salts. It causes detoxification of harmful elements, like it stores heavy metals and other foreign elements by removing them from blood and reducing their effects on the tissues. It is released and excreted later. So whenever there is an excess of any minerals, that goes and gets deposited in the bone. Bone ella adiyum vaangikirudhu, vaangi thaangikirom. but it keeps the blood clean, so the other body or the other systems will not affect it, and that will slowly reach in the circulation and excreted through the urine. It also has endocrine function, as I said earlier. So it produces fibroblast growth factor, FGF23, which acts on kidneys and reduces phosphate reabsorption. It produces osteocalcin, which regulates blood sugar and fat deposition by increasing both insulin secretion and sensitivity. So bone is a very dynamic organ. Many times whenever we discuss about organ, people tell about liver, spleen, brain, heart. Nobody tells bone as an organ, but actually bone is another important organ in our body. It has all these multiple functions, whatever I have said, I have listed. So it protects internal organs, it stores and releases fat, it produces red blood cells, it stores and releases minerals, it facilitates movements, it supports the body. So much of function is there for the bone. Okay. Now, this term has been repeatedly spoken about. Modeling, remodeling. Is there a difference? Slight difference only. Modeling is basically, it occurs at distinct sites. Bone formation and resorption occurs independently at distinct sites. A child has to grow as an adult. So there is a preformed already, a preformed message is delivered through the genes to the bones. Like these areas you have to grow, these areas you have to resorb, and this kind of final bone formation should occur. The preformed message is there. So for a child's bone is different. Why the number of bones are more in the child? Because they are not united. Okay. Once they unite together, they become a single adult bone. That's why the number of bones in adults is lesser compared to number of bones in the child, because there are more of, each bone can be in 2 or 3 separated versions. So the dimensions and shape of the bone changes during growth, and bone adapts to the altering mechanical demands. When the child grows slowly, the child's weight increases, his walking pattern increases, everything matters. Accordingly, the bone changes. This is called modeling. But more importantly, what is happening throughout the life, even when the child becomes an adult, is the remodeling. It's a highly coordinated process of concomitant resorption on one side and formation of specific sites. And it is responsible for the maintenance of skeletal integrity by renewing old and damaged bone. This process maintains calcium and phosphate hemostasis also. Whenever you say cell turnover, it's constantly happening in our body, isn't it? Can you give me an example where there's a constant cell turnover, which you can easily tell? Can you give an example where the cell turnover is happening daily? Skin. Another area where the cell turnover is very rapidly happening is intestine. See, if you get the diarrhea, what happens? Basically, the superficial layer of intestine is eroded, and you pass on a lot of stools. What is the treatment for diarrhea? Only replace what is lost from the body. The treatment for diarrhea is to replace what is lost from the body. Whatever the electrolytes lost, whatever the fluid lost, and whatever the energy lost, that has to be replaced. There is no medication, there is no drug treatment for diarrhea. Body will heal on its own. Okay. The endothelium will be replenished, reformed, and the diarrhea stops. So there is a constant changeover of cells throughout the body. One example is externally, another example is internally happening. The same thing is happening at the bones also. The bone also, there is a constant cell turnover. So this already, this Wolff law, Dr. Bhadwan clearly told. Okay, he clearly told the Wolff law and he explained about the same thing. So the bony structures orient themselves in form and mass to best resist the extrinsic forces. Now when I started the talk, I emphasized on exercise, isn't it? So I'm just asking the question, at what age is a bone density reaches the maximum? Is it 15 years, 20 years, 30 years, 40 years, 50 years? What is? What age? Just comment some age. 20. Any other guess? So it's actually 30. So if you see here, the bone age reaches the maximum around the age of 30. Thereafter it starts falling. So the best age to start the exercise, or the best age at which you can retain a good amount of bone, is between 20 to 40. Okay, so between 20 to 40 is the one where one has to do the maximum to retain the maximum bone mass, to retain the maximum calcium in the bone. If you miss the bus, of course you can still do exercise and keep yourself healthy beyond 40, but by the time you start, the later you start, you are starting at a lesser bone mass. Okay, so it is always better to start your exercise and other health related matters from now, from 20 years onwards. So 20 to 40 is the age at which you have to be very active. Whenever I say active, doesn't mean you have to go to the gym daily morning 1 hour. The activity should be part and parcel of your life. Okay. I told that my father was going to the school by bicycle, right? So I can tell that myself, I am from my hospital is 4 to 4.5 kilometers distance only, very short distance, but I am going by bicycle. I am not going by car. I am going by bicycle and coming back by bicycle. Just looking at my father, I am telling myself that at the age of 74 years, if I go to somewhere, I should go on steps and I should not depend on the lift. So the exercise or the physical activity should be part and parcel of our life. Doesn't mean you have to go to some specific gym and do some exercise for 1 hour in the afternoon or 1 hour in the evening. Okay. So with that only you can maintain the bone mass. So the bone remodeling cycle, we are coming to the important topic. It has 5 phases. We have activation phase, we have resorption phase, reversal, reformation, then mineralization. All these things are constantly happening. At one part it is happening, other part the other one is happening. And because of these things, under normal conditions, the resorption equals formation. If resorption exceeds formation, then that's called osteoporosis. Same thing in the picture format, as you can see here. Hematopoietic stem cells are there. Okay, they form pre-osteoclast and they form osteoclast. So in the bone, the osteoclast will cause the resorption. And then the reversal phase starts. The mononuclear cells will form pre-osteoblast. The mesenchymal cells, the mesenchymal cells also will form pre-osteoblast. These two will be converted to mature osteoblast. Osteoblast is the one which is layering the new bone, matrix deposition. And over is calcium and phosphorus will come and deposit and will become a mature bone. So on one side you have osteoclast, another side we have osteoblast. Can we say osteoclast as our enemy? No, it's not an enemy. It has to be there. On one side this has to occur, and the other side that has to occur, and both should occur simultaneously in the uniform way so that bone will remain stronger. Okay. So osteoclast is basically removing the older bone or used up bone and trying to replenish. Osteoblast is filling it up. If the osteoclastic activity is in excess, he develops osteoporosis. Okay. There are some congenital heart conditions or congenital conditions where osteoblastic activity is in excess, where the bone will become very dense. Okay. That's not the topic for today's discussion. The condition where the osteoblastic activity becomes in excess, it's itself a disease. So anything in excess is a disease. We have to have it in optimal. So what are the cellular players for all these things? So I said osteoclast, I said osteoblast, and osteocytes. So osteoclast are derived from monocyte lineage. They resorb the bone using acid proteases. Osteoblasts are formed from mesenchymal cells. They produce osteoid type 1 collagen. This also Dr. Parthiban mentioned. This type of collagen is called osteoid collagen and regulated by the WNT pathway. So WNT pathway is beneficial. RNKL, if it goes in excess, it is harmful. RNKL is causing bone resorption. Just remember this. RNKL, bone resorption. Rank L, ligand. L stands for ligand. I will come to this again later. If there is excess of RANKL, there is bone resorption is excess. If there is good amount of WNT activation, the bone is healthy. So osteocytes are former osteoblasts that got trapped in the bone matrix, which forms about 90 to 95% of bone cells. They are the true regulators. They secrete sclerostin. See, what is the function of osteocyte? Osteocyte secretes sclerostin which inhibit bone formation. Again, this is a compensatory mechanism. Okay. Whenever there is some sort of influence on the bone, the sclerostin will be over secreted. Suppose if you do regular exercise, there is a strain on the bone by the muscle, the sclerostin secretion is suppressed. So if you use the muscle, if you hypertrophy the muscle, and the bone ends are pulled by the muscle, this strain suppresses the sclerostin. If the sclerostin is suppressed, then bone resorption is inhibited. That means bone formation is stimulated. So all these three things, they act in a very balanced way so that we have a healthy bone. So how do we understand the bone remodeling? As you can see here, 8-year-old femur fracture. They have not been even put plates or whatever. Maavu kottu kuda pota maari theriyala in the example. Probably there is some kind of plastering there. But you see, bone tries to reconnect by itself from this state. It comes to this state and subsequently becomes a very, that is the power of the children. Madam told so many examples how why the bone healing is much easier and faster in children, because children are having very, very active bone, growing bone. That's why fracture in children is rarer than fracture in adults, but even it occurs, the healing is faster and the healing occurs to the fullest. Okay, so a bone like this will become a bone like this in children in 6 months' time. So what are the factors affecting this bone remodeling? All these factors: gravity, body weight, physical activity, bed rest, effort, muscular contraction, all will affect the bone growth. These are the mechanical factors which I have listed there: age, sex, genetics, hormones, local factors, diet, work, and occupation. Now I am going to ask one question. Suppose somebody is obese, he has a lot of fat. What will be his bone strength? What will be his muscle strength? More than a normal lean individual or higher than a lean individual? Just guess. A person is obese, he is otherwise fine. அவரோட சண்டைக்கு போக முடியுமா நம்மளால? உன் கிளாஸ்லேயே குண்டா இருக்கிற பையனோட சண்டை போக முடியுமா? முடியாது. Because he is obese, he is overworking. His bones are stronger than your bone. His muscle is also stronger than your muscle. So many obese individuals are healthy obese individuals. Okay. So why am I bringing this point? Suppose this healthy individual undertakes fasting to lose weight, or he takes some medications to lose weight. He loses weight. What component loses? Fat comes down. But is the fat alone comes down? No. There will be a loss of bone and muscle mass also. So in the body, we divide into two parts: fat mass, lean body mass. The lean body mass consists of bone and muscle. So when an obese guy loses the weight reduction occurs both in the fat component and also in the muscle and bone component. Okay. Now he has lost weight. If you go and fight with him, it will be easy to fight with him now than when you went to fight with him earlier. Not because he has reduced the weight, because he has lost his bone and muscle mass also. Now imagine this boy who lost the weight stops all his activity to lose the weight. He regains the weight, correct? Anybody actively loses the weight, if he doesn't continue the same activity, he regains the weight. Once he regains the weight, the regaining weight will be fully fat. So a person who was obese with good bone mass, now he continues to remain or become an obese person with lesser bone and muscle mass. Okay. So what I am trying to say is that it is easy to lose bone mass, but building is difficult. It needs constant activity. So physical activity is so important. The physical activity is related to bed rest and effort. It in turn kind of acts on the body weight. And these are the various secondary messengers. So RNKL, BMP, interleukins, CSF, colony-stimulating factors, TNF, TNF beta, insulin-like growth factors, parathormone, vitamin D, and calcitonin. So bone has a significant role in calcium and phosphate vitamin homeostasis, which we have discussed already. So serum calcium and phosphate must remain tightly regulated. 4 organs are involved: bone, kidney, intestine, and parathyroid gland. When calcium falls, parathormone increases. Parathormone stimulates osteoclast through RNKL, which increases renal calcium resorption, decreases phosphate reabsorption, and activates vitamin D. Vitamin D increases intestinal absorption and calcium phosphate, and thereby they are trying to maintain the serum calcium. When parathormone increases, yes, serum calcium remains normal. But what happens? There is deficiency of calcium in the bone. This is the axis by the rank and OPG axis. I think you can just skip. All these are kind of theoretical pathway you can read out. But basically it is easy to remember. Remember sclerostin, remember WNT pathway, and remember the rank. Higher the rank, higher the osteoclastic activity, more is the bone reabsorption. Okay. Higher the WNT beta catenin pathway, more will be the building of the bone. Sclerostin is again a negative factor. As you see here, it stimulates osteoclast. It inhibits osteoblast. But whenever you have loading forces, as I said, muscle activity will inhibit the sclerostin secretion from the osteocytes. Okay. So these are the various bone turnover markers. These are for bone formation. We have 3 markers: PLP, PLNP, bone ALP and osteocalcin. When these are increased, it indicates that there is active bone formation. So in children, this will be elevated. For bone resorption, we have CTX and NTX markers. These are all indicator of bone resorption. So this is a fine balance between the bone formation and bone resorption. So bone formation is by the BMP, by the WNT pathway, okay, intermittent parathermone. Intermittent elevation of parathermone is important, okay, mechanical load and androgens. Whereas bone resorption, all the other things. So these are the, again, whatever I have been saying, it's a repetition of whatever I have said. All these things will lead to less deposition of bone, aging, lack of weight bearing, reduced activity, chronic malnutrition, alcoholism, hypercortisolism, all will lead less deposition. All this disease activity will increase the removal. This will lead to what we call as osteoporosis. So why do we bother about osteoporosis? Because if you see the breast cancer incidents, stroke incidents, heart attack incidents, and you see the osteoporotic fractures, they are 3 to 4 times than the other common diseases. So osteoporosis related fracture is so common that we cannot ignore. That's one of the most common morbidity causing, even mortality causing problem of our society. About 1 in 3 women and 1 in 5 men over 50 years will have osteoporosis. 40% of all women over 50 will suffer osteoporotic fractures. See, 40% is a very, very high number. That means nearly 50%. 1 in 2 men will have some kind of fracture. It's a very high fracture. So lifetime risk for getting osteoporotic fracture for women is higher than getting breast cancer or uterine cancer. So as a girl, nobody should kind of really worry about uterine cancer or breast cancer. Of course, you have to take precautions, but more importance has to be given, how can I prevent my own fracture? So there comes the classification of osteoporosis, primary and secondary. Primary is type 1 post-menopausal. Secondary is senile, which is both common for males and females, whereas secondary is the result of other diseases, and these are the long list of secondary causes. We have endocrine metabolic causes like hypogonadism, hypercortisolism, hyperparathyroidism, hyperthyroidism, diabetes. All these things will cause osteoporosis. Renal failure, lymphoproliferative disorders, malignancy, malabsorption syndromes, alcoholism, and things like that. I did mention about steroids, which is one of the most common cause of osteoporosis in the current scenario. So I'll just start with one slide on symptoms, and then subsequently how to diagnose osteoporosis and how to be treated will be in the next session. Okay. So the symptoms of osteoporosis are, they may simply come with back pain and stiffness. There may not be any other symptoms. Some back pain, stiffness. Periarticular pain and stiffness. Sometimes just a diffuse body ache may be actually a presentation of osteoporosis. Easy fatigability, early tooth loss, and loss of height. The loss of height is because in the Mari they lose the spine height and then they become loss of height. And very easy fractures. Very so-called small kind of injury or very insignificant injury will cause fractures. Whenever there is an easy fracture, we can understand that there is underlying osteoporosis. Again, these are the signs of osteoporosis. Okay, just to complete the list. So how to evaluate and treat the osteoporosis? Stay for the next lecture. Okay, next lecture is going to be on that. What is the role of DEXA scan? What is the role of other scans? What do you mean by bone densitometer? Everything will be discussed in the next slide, next talk. So I am just bringing back to the original, my initial slides on bone metabolism. By remembering all the metabolism pathways, that can be clearly linked to the treatment aspect also. Welcome, sir. Thank you. So we discuss about bone regarding resorption on one side, formation on other side. How are we going to prevent the resorption? We can prevent the osteoclast apoptosis by using biphosphonates. We can block the RNKL by using denosumab. We can kind of simulate the intermittent parathermone activation by giving teriparatide. We can inhibit the sclerostin by using romosozumab, and we can supplement the estrogens with SERMs to reduce the resorption. So these are the kind of, all these things will be detailed next lecture. These are the therapeutic way of intervening osteoporosis. So the key takeaways are, bone is dynamic, remodeling imbalance causes osteoporosis, RNKL and WNT are the central pathways. Estrogen loss in the post-menopausal women is critical. The treatment is pathway targeted. So, osteoporosis is not a disease of low calcium, please remember. It's a disorder of remodeling imbalance. Trabecular bone is affected first. Bone turnover markers predict the future risk. Early menopause means high risk. So, we have to have all this mind. When we understand biochemical hemostasis, prevention and treatment, the treatment becomes very intuitive. Okay. Thank you very much for the opportunity. Thank you.
Hello, Kannan sir. I want a few words about the cardiologic problem. Actually,
Right.
that means you're being cardiologist. I told you already. The bone, the calcium discharge from bone deposit cardiovascular system that cause ischemia and the calcification of the vessel result in the cause of death. A few words about that one. Being cardiologist, you want to.
Yes, Sir's question is, we do hear about calcium deposition over coronaries. Is it anywhere related to the bone metabolism? The answer is no, sir. It's a kind of dystrophic calcification. You know, whenever there is excess calcium, the excess calcium goes and deposited, gets deposited in many places. That's called metastatic calcification. This is dystrophic calcification. This atherosclerosis is induced in the vessel, and there is fat deposition and calcium deposition. There need not be high LDL in the body. Somebody can have normal LDL, but still there will be cholesterol formation and deposition in the arteries. This is a process of atherosclerosis in the arteries. So, at the maturation of atherosclerosis, when the layer of cells die, calcium won't get deposited there. So, calcium deposition is not going to harm the individual. That's an indicator of underlying atherosclerosis. So, if you detect calcium by CT scan, that means there is atherosclerosis. The amount of calcium does not correlate with the degree of coronary stenosis. In somebody's CT scan, calcium score may come very high, 1600. If you do coronary angiogram, that may be a mild, some 30%, 40% blockage. Somebody may have a calcium scoring of some 350. But if you do the coronary angiogram, there can be 90% stenosis. So, the calcium deposition on coronaries, it does not correlate with the degree of severity of the coronary disease. But it means there is CAD. It means he needs to take antiplatelets, he needs to take statins, he needs to take other lifestyle measures to prevent the further progression of atherosclerosis. So, this calcium deposition has got nothing to do with serum calcium. This calcium deposition has got nothing to do with the bone metabolisms. It's the same thing, how the calcium deposited on the aortic valve. In old age, one of the morbidity causing diseases is aortic stenosis because of the calcium deposition on the valve. Wherever there is wear and tear and loss of accumulation of dead cells, calcium goes and deposits there. So, in aortic valve, a senile degenerated aortic valve, the endothelial or endocardial lining cells die and calcium goes and gets deposited there. So, he develops aortic stenosis. So, the calcific aortic stenosis or calcification of the coronary arteries are not linked to the bone metabolism.
Thank you, sir, for the clear session. I have always enjoyed your sessions. Happy to chair your session today.
Thank you.
So, few carry-home messages for the students. Don't miss the bus. You are in your 20s and 30s to start exercising. Sir is a good motivator for fitness. He is going by cycle. He goes for trekking.
Yes.
His YouTube videos on diet is very clear and gives good information to the old people also.
Thank you.
And that is one message. Second message is, if your parents, mom or grandmothers, they are in their 50s and 80s, screen for them for osteoporosis. The prevalence is very high. So better to screen and prevent osteoporosis. And one good thing about being obese is bone mineral density, I think.
Exactly.
That is a drawback for lean individuals.
Exactly. Right.
Thank you, sir.
Thank you.
Actually, bone metabolism is a very dry topic.
Yes.
You made it in a very fantastic way. Especially the one point you gave for the budding young people. Do not, if you understand the concept and logic, no need to memorize the treatment.
Exactly.
That's the take-home message for the kids. Excellent and wonderful session. Thank you, sir.
Thank you, sir. Thank you. Thank you.
Thank you, sir. The depth of your discourse has turned this session into a masterclass.
Good morning, everyone. Respected Dean Sir, Dr. P. Sri Saravanan, Veeramani, respected Vice Principal Sir Dr.M. Saleem, respected Deputy Superintendent Sir Dr.Suresh.Babu, distinguished speaker, chairpersons, faculty members and DS students. A very warm welcome on behalf of the Department of Anatomy, Government Medical College, Dindigul. With this excitement, we are immensely proud to announce that this is the first time inter-college online digital art and slogan competition for all phases has been outcome. I am delighted to welcome you all to this continuing education program on osteoporosis prevention. Osteoporosis prevention, structure to strength. Today we explore the journey of bone as bone boon, where we have discussed about the formation and dynamics of bone. Bone bond, where we have discussed about the origin of bone and embryology. Bone bond, where we have discussed about the bone metabolism. To strengthen not just our knowledge, but our responsibility towards preventing osteoporosis. With TNMC credit hours and university credit points awarded, this CEP reflects our commitment to academic excellence and lifelong learning. Let us engage, learn, and build stronger foundation for stronger bones and stronger healthcare. Welcome once again, and wishing OSTEOPREV 2026 a grand success. Thank you.
I extend my welcome to our ARMO sirs, Senthil Kumar sir and Selindi Kumaran sir, and our TNMC observer, Ilango Muniyappan sir, and our Thirlov Chandran sir. Welcome, sir.
நம் நிகழ்ச்சியை தொடங்குவதற்கு நம் வாழ்வின் அச்சாணியாக இருக்கும் நம் தமிழ்த்தாயை வணங்கி தொடங்க நம் மாணவர்களை அழைக்கிறோம். எங்கள் அன்பிற்கும் மரியாதைக்கும் உரிய பேராசிரியர் பெருமக்களையும் மாணவர்களையும் தங்களது இடங்களிலிருந்து எழுந்து நிற்குமாறு தாழ்மையுடன் கேட்டுக்கொள்கிறோம்.
கடலுடுத்த நிலமடந்தை கெளிலொழுகும் சீராரும் வதனமென திகழ்பரத கண்டமிதில் தெக்கணமும் மதில் சிறந்த திராவிடனல் திருநாடும் தெக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிலமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Light is an energy. Light is a form of divinity. To make this event even more auspicious, I would like to welcome our Honorable Dean Sir, Dr.J.Sri Saravanan, Medical Superintendent Sir, Dr.Veeramani, Vice Principal Sir, Dr. Saleem, and Deputy Superintendent Sir, Dr.T.SureshBabu to light the lamp. I now kindly request our honorable dignitaries to take their seats on the dais. I now kindly request our honorable dignitaries to take their seats on the dais.
I would like to welcome our esteemed Professor and Head of Anatomy Department, Dr. Jayarani M.D. to deliver the welcome address.
Very good morning to one and all present here. Hearty welcome to our beloved Dean Sir, respected MS Sir, VP Sir and DS Sir, and the supportive faculties of our RMOs, ARMOs, and our special speakers and mind-blow chairpersons, moderators, and valuable senior persons, and our Government Medical College Dindigul family friends, and the very lovable students. I heartily welcome to our outstanding teaching experience of the excellence in our OSTEOPREV program 2026. We are conducting first time online on Department of Anatomy, first time conducting the hybrid mode, and this is the first time implementation of the online competition for all phases of the student at the state level. Even we have received the registration from the AIMS, sir, so we can convert this as a national level program. Thank you for all the participants and the supportive faculties for this wonderful program. And once again, I hearty welcome to all of you. Thank you for the wonderful opportunity.
Thank you, ma'am.
I would like to invite our respected Dean Dr.Sri Saravanan sir to address the gathering.
Privileged to be a part of this OSTEOPREV 2026. I appreciate Department of Anatomy for organizing this kind of CME. This is a hybrid CME. This is telecasted all around in the YouTube. All the persons can be seen this. So your knowledge can be spread to the worldwide. Any persons can be reached that thing. In Dindigul Medical College, we have conducted a lot of CMEs. More academic programs are going on here. This is the second online CME. This is the second online CME conducted here. Previously, your faculties are conducting this another online CME. These CMEs are it's a eye opener to all the UG students. You utilize the stalwarts here. You can see the B.R.J. Kannan sir, Balamurugan sir, and Parthiban sir. They are experts in their field. They have wide knowledge. Apart from that, they are able to tell a lot of things to you apart from the academic activities. If you see B.R.J. Kannan sir as our pharmacology professor told, he is an excellent sports person. He is a good speaker also. He will tell everything. He's popular in social media also. So if you follow him, you can learn a lot of things from him. So I request the students to follow him, our Parthiban sir and Balamurugan sir, follow him and carry away the messages they have passed to you. You utilize this opportunity. This is a wonderful opportunity. You improve your knowledge and you in our government setup, we are having lot of infrastructures. In anatomy, we are having more number of cadavers. You can do cadaveric workshop for future also. You use the resources to impart your knowledge to the world. With these words, I thank you for the Department of Anatomy organizing this workshop. Thank you very much.
Thank you, sir. Your words have perfectly encapsulated the spirit of excellence we strive for this institution. I kindly request Saleem sir to take his position on the dais. I now kindly request Dr. Jayarani ma'am to honor our respected Dean sir, Medical Superintendent sir, VP sir, and Deputy Superintendent sir.
Now I request our Honorable Dean sir to felicitate Dr. Parthiban sir. Now welcome our Dean sir to honor our HOD and Professor of Department of Anatomy, Dr. Jayarani ma'am. Now I request our Dean sir to honor Dr. B.R.J. Kannan sir. Now I request our Dean sir to felicitate Dr. Balamurugan sir in the stage.
I request our respected Dean, sir, for online competition which was conducted for the first phase MBBS to the final phase MBBS. In various colleges, we have collected the reports and we have selected the very excellent presentation of the anatomy art on the digital art and the leaflet related to the community oriented and the patient outcome. Now I request you two to distribute the prize for the our college's winners, sir.
Digital art competition, third prize has been won by Priyanka Bharati 2022 batch, Government Medical College, Dindigul. Second prize by Manasa M, Madurai Medical College. First prize by Rabita R.T, Stanley Medical College. Bone Health Awareness Slogan Contest, third prize is won by S.T. Reshma 2025 batch, Government Medical College, Dindigul. Second prize, Abdul Bashir, yes, Velama Medical College, Hanna Hospital, Madurai. First prize is won by Bharati Nithi, yes, Government Sivagangai Medical College. Patient Education Leaflet Design, third prize is won by Sri Darshini M, 2023 batch, Government Medical College, Dindigul. Second prize is won by Ajay Shabnan, SK, KAP Vishwanath Government Medical College, Tirshi. And Sarveshwaran RK has won the first prize for Government Medical College, Coimbatore. Thank you so much, sir.
I kindly request everyone to stand for the national anthem.
शुभ नामे जाहे तव शुभ आशीष माहे गाहे तव जय गाथा जनगण मंगल नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
we welcome Dr. V. Trilokachandran Sir, Associate Professor of Surgery, and Dr. Kamali Ma'am, Associate Professor of Community Medicine, GMC Dindigul. Following a brief respite, we reconvene to examine the mechanics of mobility and the regenerative capacity of the skeletal system. We focus here on the synergy between form and motion and the clinical artistry involved in the mending of human frame. It is a privilege to introduce Dr. B.R.J. Satish Kumar Sir, Senior Consultant and Orthopedic Surgeon, B.R.J. Ortho Center, Coimbatore, as our featured speaker. We also extend a respectful welcome to our chairperson, Dr. V. Trilokachandran Sir, Associate Professor of Surgery, and Dr. Kamali Ma'am, Associate Professor of Community Medicine, GMC Dindigul, to guide the session.
Satish. Good morning, friends. I am privileged to be a part of OSTEOPREV. Everything about calcium. Respected Dean Sir, we welcome you all, the students, faculties, and my dear friends. I invite Dr. B.R.J. Satish Kumar. Satish sir, you are welcome here. So about B.R.J. Satish Kumar, he is also a very big scholar. He is a student of Madurai Medical College, and he got gold medal in all subjects: anatomy, medicine, dermatology, ophthalmology. Being a alumni of Madurai Medical College, I know both of them, B.R.J. Kannan sir and B.R.J. Satish, and both of they are brothers. And Satish sir is fond of calcium, and Kannan sir don't want calcium. So he is an undergraduate of Madurai Medical College and gold medalist of all subjects, MS Ortho at PGI Chandigarh, and DNB Ortho National First Gold Medal by Dr. APJ Abdul Kalam, fellowship in pediatric orthopedics, and is 20 plus national and international publications. Neck of femur screw fixation in elderly. Bakshi Best Paper Award from Hinduja Journal of Orthopedics, and the different approach, that is the lateral approach for TKA in fixing valgus deformities of the knee, one of the unaddressed portion of the orthopedics, and the Kabanji technique in pediatric distal radius fracture. Usually that is managed conservatively, but here the management of distal radius fracture is different. The cement usage in total knee arthroplasty, and Kabanji technique in supracondylar fracture. We welcome you, sir. We give a small introduction about calcium, then it is over to you, sir. So as you everybody know that the daily calcium is one of the important mineral, so everything they taught about calcium. So the minimum calcium requirement for everybody per day is 1 gram. 1 gram. 1 gram is the answer, daily requirement. And the calcium will not go without vitamin D, because vitamin D is having a hormone-like action for the calcium deposition. So the daily requirement of vitamin D is 600 international units. 600 international units. So you need all calcium comes through the food supplement only. So in vegetarian diet, you have all green vegetables, leafy vegetables, all nuts, milk will have the rich of calcium, and don't forget the ragi. The ragi is one of the richest source of calcium, and the all non-vegetarian diet and egg will have calcium. So the significance of calcium in your age group, that is people less than 30 years of age group, is that the maximum mineralization occurs before 30 years. Almost the total mineralization occurs before 30 years. So the people below 30 years should have their calcium deposition adequate, so that your remaining period will go smoothly. So that is the significance of this age group people to listen about calcium. And finally, a word about osteoporosis in perimenopausal or postmenopausal age group is the calcium metabolism is influenced by your estrogen, and when the estrogen is reduced, the mineralization is also reduced. So at your perimenopausal age group also you need extra calcium. Pregnancy you need extra calcium. Less than 30 years you need extra calcium. So like that, the calcium is one of the important thing, and vitamin D you get it from the sunlight. So the sunlight will stimulate your skin, and you get vitamin D3, which influence further active absorption of the calcium in the digestive system and the distal convoluted tubules. So with this small calcium introduction, we request Dr. Satish Kumar sir, to take over the dais. Over to you, sir.
We kindly welcome Resident Medical Officer Bhuvaneshwari Ma'am to this event.
Hello. Hello. Is it audible?
Yes, you are audible, sir. Some disturbance, but you are audible.
Hello.
Sir, you are audible, sir. Go ahead, sir. Audible, visible. Slides are so shared. Welcome, sir.
Hello. 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 Hello.
Sir, you are. Hello.
At the outset,
Sir, உங்கள் ஸ்க்ரீன் அது மியூட் ஆயிருக்கா சார்? ஸ்க்ரீன் மியூட் ஆயிருக்கான்னு பாருங்கள்.
hello.
Correct, sir.
Yeah. So I thank the anatomy department for arranging this program. I think actually a few topics should have been already covered in osteoporosis, I think. And I will start from diagnosis, prevention and treatment. So the clinical features of osteoporosis is basically a silent disease, and it can have non-specific symptoms like back pain, back stiffness, easy fatigability, and most of the time it presents with a fracture, what we call as a complication of osteoporosis. So these are the various signs. Okay, so we'll start with how to diagnose and what to investigate in osteoporosis. Am I audible? Hello?
Sir, you are clear, sir. Very clear.
Hello?
Sir, you are audible. Go ahead, sir.
Hello?
The person you are speaking with has put your call on hold. Please stay on the line. நீங்கள்
So osteoporosis can miss the minor fractures. It is difficult to quantify osteoporosis with X-rays. By repeatedly seeing the X-rays, we will have an idea what is the bone density. So on the left side, you see this is the lumbosacral spine X-ray lateral view. This is a normal X-ray. If you see on the right side, the moment you see the X-ray, you will squeeze your eyes to see the bone. That means the bone is rarefied or there is osteoporosis. So diffuse uniform whiteness you can see on this X-ray. This is the normal bone density. This is less bone density, what we call poor bone quality. And in the spine, the earliest thing what we see is the loss of horizontal trabecular bone. The spine is a cancellous bone. It is made with equal amount of horizontal and vertical bone trabeculae. When the horizontal bone trabecular is lost, you will see the vertical trabeculae. If you carefully see, you can see some lines inside the vertebra here. So this will suggest that it's all osteoporotic changes. If you see very prominent trabeculae, then you have to think that there is definite demineralization osteopenia compared to because the radiographers, they use the same voltage, they use the same current. And in a patient with osteoporosis, if the trabeculae look very prominent in a cancellous bone, then you have to think of osteoporosis. And then you see this shape. So this is the normal shape. This is a rectangle vertebra. This is the biconcave shape. You can see this is a concavity on either side, otherwise called codfish vertebra. These are all late changes. Already the osteoporosis has progressed very well to produce these type of fractures. Then we have bone mineral density scans. These scans can directly or indirectly measure the bone mass. They can estimate the bone mass, which is measured as given as gram per centimeter cube. And it is compared to normal individuals, and then it is expressed as scores. So what is the use of these scans? So these scans can predict the fracture very well. Ultrasound is the commonly used scan. It is done at calcaneum or wrist. Various parameters are checked. The advantages is it is cheap, portable, but generally it is used only as a screening. It is used in a lot of camps. You would have seen osteoporosis camps. So in those cases, we can screen hundreds of patients in short time. And the disadvantages are poor precision, difficult to calibrate. And whichever patient has got problems with this quantitative ultrasound, then we have to confirm the same with the more specific test, that is DEXA, dual energy X-ray absorptiometry, which is the gold standard thing. This is something like a CT scan machine. The patient has to simply lie down. The bone mineral density is measured at two places. Generally, it is measured in the central. Central means it is the vertebra, the neck of femur. Peripheral, it can be measured in the distal forearm and in the fingers, other areas. So there's a peripheral DEXA where you measure at the peripheries like distal tibia or even the foot bones and the distal radius. This is the most valuable test or single most important test. The spine is centered, and then the both iliac should be made visible. The scan includes, it starts from L5 to T12, middle of the L5 to middle of the T12 vertebra. And the total hip joint area of the femoral neck is scanned, and the score is given as what is called a T-score. So T-score is reference to mean bone mineral density with respect to young adult population. The T-score is given as equal or -1 means normal. When the T-score is between -1 and -2.5, it is osteopenia. When it is more than -2.5, that is lower than -2.5, it is osteoporosis. With a fracture, we call it severe osteoporosis. So this is the WHO definition for osteoporosis is the T-score, which is -2.5 or lower than that, that is -2.7 or -3, then it is definite osteoporosis. So coming to the prevention, you would have already seen this chart. So we have to achieve the peak bone mass. As Sir was introducing, Sir was also telling that this bone mineral is important in young age. So you can see in the younger age group, say from 25 to 40, the bone mass is more or less flat, in the sense it has reached a plateau. After that, it starts declining. Before that, only it is steeply increasing. So the bone mineral density and bone mass, bone strength, everything increases from birth, say up to 20-25 years. At the time, you hit what is called the peak bone mass. And you have to, it is getting maintained for another 15 years. After that, slowly it is declining. So if an individual is not achieving the peak bone mass, I mean, if you do not reach or hit this peak, to start with itself, your bone mass is weak. Then with subsequent age, you will become osteoporotic very soon. So this is like bone bank investment. What is your current bank balance or bone strength? The current bank balance depends on the opening account, how much deposit you make, and how much withdrawal you make, say every week or a month. Similarly, what is the current bone mass? The current bone mass is determined by the opening account, which is nothing but the peak bone mass. And what are the activities you do to promote new bone formation? And what are the activities you do or you don't do which promotes bone removal? So this balance defines the peak bone mass. So how can we increase the peak bone mass during the growing years? Regular physical exercises and a diet which is balanced diet with adequate protein, calcium, and vitamin D. And exercises are important. We always say this, you use it or lose it. That means you have to use your bone and muscles. If you do not use them, you are losing the bone quantity and quality. The bone gradually will become weak. So suboptimal loading of the bone will result in suboptimal peak bone mass in children. So they won't reach their adequate bone strength at the age of say 20, 25. If they don't reach at that point, then again they'll be losing that very fast in the elderly. So different type of exercises, impact exercises, directly loading the bone, and any physical activity can be done or should be done based on the age and the fitness level. Running, jogging, skipping, cycling, any type of sports activity, and minimum 30 to 60 minutes per day is essential. And muscle strengthening exercises without resistance like push-up and straight leg rises, or with external resistance like free weights, dumbbell. Whatever the force you give the muscle, the force is transferred to the bone because muscles are originated from the bone. And balancing exercises, especially for elderly, to prevent fall. And the nutritional deficiencies, as we know, calcium deficiency, vitamin deficiency, all and protein deficiency, everything can result in osteoporosis. Protein deficiency, the simplest thing we can know is the bone has got collagen 1 protein as a basic component, bone matrix component. And it also, through insulin-like growth factor, it stimulates osteoblast proteins. So proteins is the proteins which are rich food. And the calcium requirements, that has already told an adult, ideally adult, 25 to 64 years, you'll see we need 1,000 milligrams of calcium per day. And the calcium in food is very less. The routine food, what we take, the cereals, rice, wheat, maize, they don't have calcium. The cereal product that has got calcium is ragi. And again, the protein things which has got calcium is Bengal gram and Moscow. Again, they're all very less. And milk and milk product has got good calcium. And if you take the so-called vegetables, soybean, others have got negligible calcium. And greens, the most important rich source of calcium is the greens. And most of the seafoods have got some common calcium. The vegetarian food rich in calcium, the non-vegetarian food. And coming to vitamin D, the adult daily requirement is 1,000 to 1,500 units per day. Initially, it was 200 to 400, now it has gone up. And vitamin D is rich in dairy products, fish fat, fish oil, and dairy products. And contrary to the popular belief, sunlight is not going to produce vitamin D just like that. We have got 70 in our skin. Upon exposure to sunlight, UV rays D, that will get reconverted into vitamin D, what is called inactive form of vitamin D, and then it get aggregated in the liver and kidney. So the solar intensity affected by multiple factors where you live, the time of the season, and environmental factors. So time is say 11 a.m. to 2 p.m. Duration is approximately 2 hours, and exposure is maximum day. So we practically see wearing full and sleeves and wearing a full pant and then you just move around the sun. We will expose only your face. There's not sufficient, and only 2 p.m. where you get the maximum most of the time we don't go for walking the time. So practically from sunlight exposure, what we gain is very minimum unless you are agricultural laborer working in the field without shirt. These are the harmful diet habits that promote bone weakness in young children and adolescents. Skipping meals, avoiding milk, avoiding fat, high carb fast food, canned drink, sedentary lifestyle, alcohol. Again, prevention of osteoporosis means prevention of fall is a very important component, especially in elderly. Elderly have got multiple reasons to fall. It can be started from the eye, it can be less high BP, low or blood sugar, neurological problems. Whatever reason they fall, they will get osteoporotic fracture. So we have to prevent fall. We have to treat the various problems that can lead to fall and keep the floor clean, leveled. The mat should be rough, mat should be placed, adequate light should be there, and various supports should be installed like toilets and bathrooms, staircases, and various supports so that they don't fall. So next comes the treatment. So treatment, whatever we have said for prevention holds the same. And the treatment, number one, the top of the treatment is physical activity. Most of the patients, they simply take calcium and just lie down, it's not going to help. It will not work at all. You take calcium and you just lie down, that's not going to work. That calcium will not enter the bone. So physical activity is in the top of the triangle, and other stage is about diet, and third thing is supplement and drugs. So calcium supplementation is generally a postmenopausal female and in general elderly patients and people who have poor dietary habits and young patients who have got a problem. So which type of calcium in the market? We have got multiple calcium salts, carbonate, citrate, malate, orate, phosphate, and lactate. Calcium citrate malate seems to be the best salt. It has got good amount of elemental calcium and a better absorption rate. Good amount of elemental calcium means the calcium tablet size will be small. It is easy for swallowing in elderly patients. And so the various brands available. Again, vitamin D supplementation is easier nowadays. And simply check the blood levels, and if the blood levels are less, then you can supplement. We have got supplementation alone, that is vitamin D per week. For 6 weeks we give, and then you can follow that by monthly once, that is high dose vitamin D supplement. If the patient has got liver and kidney problems, you can supplement with the active form of vitamin D. That is calcitriol can be added. So various combinations are available. This is calcitriol combination 125%. Along with that. Right. So these are the other additive calcium available with isopropyl. They don't do much. In calcium, we have to always add vitamin D and exercise this, as I said earlier. Calcium should not be mixed with iron, should not be mixed with supplement, not be mixed with tetracycline detoxin, because the calcium absorption becomes very weak. And coming to the drugs, we have got two group of drugs. One is anabolic therapy, which promotes newborn formation, that is teriparatide. The other is anti-resorptive drugs that will prevent or reduce bone resorption. In this, we have got three group of drugs: biphosphonate, benzomab, and selective estrogen receptor molecules. So teriparatide is a drug of choice in most of the patients. It is basically derived from parathormone, synthetic parathormone. Among the full parathormone hormone, the 84 amino acid peptide, the first active 134 N-terminal amino acid peptide is recombinantly devised and is available in the trade names. The dose is 22 by 40 microgram daily. The substitute is injection. It's like an insulin injection. And the duration of treatment is 1 year, maximum 2 years. So various companies have got now. The cost was very high, up to 7,500 per month. Now it has come down to 2,000 rupees per month. So this is we have got disposable cartridge, and each cartridge has got around 7 micrograms, and each ml will give each injection will give 29. So several studies have shown that has got a very good result. The next group is biphosphonate. Biphosphonate, we have got multiple generations. Each generation is potentially more. Simply what we can remember is we have got oral biphosphonates and we have got injectable biphosphonate. The mechanism of action is it directly acts on the osteoclast, reduces the action of osteoclast, and indirectly stimulates the osteoclast. So the major action is anti-osteoclastic action. So it can be used in any type of osteoporosis. It increases the bone mass, and these are the drugs available. Alendronate is a weekly one. Izidronate also is a weekly one, oral medication. Ivabradonate is a monthly one, oral medication, and zoledronate is yearly one, IV. So based on patient choice, we can also select the drug, and very minimal quantities of drug. So it should be given only with water, and it has got high incidence of reflex exposure. So upright for 1 hour after taking the drug, and the duration of treatment is 3 to 4 years. After 3 to 4 years, it will be a drug holiday for same 2 to 4 years, and then we can restart. So we can every 3 to 4 years, the drug holiday is 1 or 2 years, then we can restart for another 3 to 4 years. So we always have a stamp which says that the patient has to take this drug in the stomach only with water, and the morning preferably, and not lie down for 1 hour to prevent hypertension. So the injectable biphosphonate is hyaluronic acid. This we can give yearly one, particularly in elderly patients who won't follow the regimen what we say. So they can be supplemented with calcium, vitamin D, along with that You admit the patient, say for 2-3 hours observation, you do this slow IV, and then you can discharge the patient. Yearly once it can be done. So these are the other drugs through various signaling pathways. The other drug is the denosumab. This is also acting against osteoclast. It's also anti-osteoclast. This injectable drug, this can be given 6 months. Again, this can be given in the patients who do not take tablets regularly. This can be given 6 monthly. The subcutaneous injection, 60 milligrams 1 ml per people. You can give every month. So the standard approach is you initially give teriparatide, increase the bone mineral, or increase the bone density, increase the bone mineral, and then maintain that with biphosphonate and give anti-dissolvant. This is the better choice. Sometimes the patient is not looking for injection, it can be only biphosphonate. So calcitonin and all other drugs, then inhibition therapy and self-usage of modifiers, they're all not given or referred by operating surgeons unless there are other indications, say patient is on estrogen hormone, is prescribed by endocrinologist or by gynecologist, then can continue. So various combinations are available with the tablet for operating surgeons where you got calcium daily and you got monthly ones, biphosphonate agonist, and this generally for the patient. So this thing have 30 tablets of calcium and 1 tablet of agonist that can be given. Again, the kit you have to check that all the elements that you see the same brand. This kit has got managed from element pack. So this kit has got one. So, but for some of this is in capsule form, this is in tablet form. So capsule form will be easier for it is small. So we have to see how much the patient can adhere to our inform. Now coming to the practice, 80% of all hospital fracture actually female because they live longer. They have got low peak bone mass to start with, and after menopause, again the significant loss of bone mass, and they have got higher risk of fall compared to males. So annually, this is approximately 15 lakh fractures happening. Why it is important? Because the incidence or the risk for a female to get the orthopedic fracture is estimated at 10 to 100 times compared to the risk of getting breast cancer. So we all talk about most of the females, they know about the breast cancer, but a lot of people, they don't bother about the bone cancer osteoporosis. The risk to get a fracture in lifetime is far, far higher than the risk of getting breast cancer or cervical cancer in female. So a simple fall, they may not even have a history of fall. They may have missed the step by standing down or they would have forgotten the first travel that big jerk to fall, and then they come back pain. So simple fall, patient comes with a loin pain or a groin pain. You have to see if you can do straight leg raising, patient can stand, patient can walk. We have to take 2 X-rays with autonomous spine, in the autonomous spine, we have seen the vertebral fracture, and in the pelvis X-ray, we have the pubic ram fracture or the fracture of the hip area. So spine fractures are the most common fractures. Different varieties of fractures are there, what we call wedge fractures or crush fractures. And this is the superior end plate fracture, very clearly visible in this kind. You can see the superior end plate, what we call this part of the bone and gone inside the different types of compression fractures. Most of the fractures can be, sometimes there will be only subtle loss of height. Subtle loss of height, there won't be this concave, sometimes concave very much. So from bottom to upward, from lumbar to thoracic spine, the vertebral side gradually increases. There's a sudden decrease in vertebral height. You have to set the fracture. Most of the fractures can be conservatively, these fractures, unless there is some neurological problem. There's a compression on the spinal cord. Most of the time, this is conservatively. The rigid brace, what we call Taylor's brace, thoracolumbar hyperextension brace, and initial few days the pain will be significant for the first 1 week to 1 week. At 10% is something that will various types of analysis. And patient can be allowed to move only with a walk. If the patient doesn't use a walker or a belt, it's mandatory to have a belt and a walker, at least for just 10 they can walk the toilet. In some cases, we inject liquid bone, what is called vertebral artery that the fluid pain is stability. So hip joints are the areas where the fracture is fractal era fracture, which is generally not in extreme persistent pain in the back. CT scan to repeat the sacral era fractures. And the pubic ram fractures, pubic and pubic ram fractures. And these three fractures can be managed conservatively. The most important fractures just below the femoral head, the intracapsular nephrophyma, and around the trochanter, intertrochanter fracture. These are the serious fractures. Multiple areas can get fractured, and most of people will ask, can give those these fractures the nephrophyma and trochanter fractures, the hip fractures, surgery is mandated because without surgery, healing will not happen. Sometimes healing can happen, or that patient has to lie in the bed for 3 months. So patient lying down, there will be a lot of complications happening. The biggest complications of immobility, big list starting from bed sore to pneumonia, diabetes, DVT, all things like that. So hip fractures are considered gateway to death. Approximately 40% of patients will die in 1 year without treatment, without surgery. More number of people will die. It has been shown that even with surgery, more number of people will die in 2 weeks. Approximately 20% of patients will die even after surgery after 2 weeks. But no surgery means within few months many patients will die. So based on the fractures, we do surgery after what's called medical optimization of patients. Most of the patients will have associated cardiac problems, other things. And this is trochanteric fracture with screw plate, what is called anatomy screw, another patient anatomy screw. These patients can be made to walk from the next day. And another patient, this is another model, highly common fracture, what is called as unstable fracture. Do rod and screw are called proximal nail. Another patient proximal nail. And this is the intracapsular fracture neck of femur. You may miss it, but if you carefully see the spike there and what we call Shenton line, operator foramen, and Shenton line disturbed. This is the fracture of femur. 3 types of treatment is one is fixed, another is partial hip replacement, that is on the head, the other is proximal, where it is so this is intracapsular of femur fixed post screws, and this patient is mobilized after 3 weeks. 3 weeks they will be mobilized in the bed. After 3 weeks they can walk. This is 96-year-old patient. Fraction of femur is lower limb, and location, and the entire leg is broken. This side, the left side, fraction of femur. You can see this normal head and neck. This patient underwent partial hip replacement, what is called osteoporosis. This is maybe arthroplasty. Patient to walk on the next. Most of it can be discharged in their 4 days. The other modality of this total hip replacement, this patient has undergone already semi-arthroplasty on one side. As you always say, but fracture, there is always the chance of another fall on another. These patients will always be there after the walking stick, otherwise they fall. So this patient has undergone semi-arthroplasty. After 2 weeks, another fall, fracture on the opposite side. So she underwent totally replacement. You can see that the artificial top and the upper, and the artificial bar with system is minted totally replacement is done. So again, most of the patients can walk. If you do artificial replacement, patient can walk first post-operative. The other common practice, the risk fractures, they are treated with what is called percutaneous. Therefore, the C-arm, I don't make mention or just manipulate it, and from outside like this, we have wires and practice will be there. In some patients, you can apply on the plaster paris. It's a shoulder fracture, again, spinning, and the other fracture is both bone fracture, the leg, where you do open taking. So the common practice is the fracture and the so in summary, we have to prevent osteoporosis from engaging. Prevention starts from engaging. Prevention will not and do not start from the age of 6. Prevention starts from engage. You have to include the big 4 marks for activity, diet with adequate protein, calcium. Treatment again the same. Along with that, we have drugs and surgery, motor fracture. So the take-home message is physical activity is extremely important to prevent and control in all ages. Calcium alone is not the treatment for osteoporosis. Drug therapy is mandatory. It should be teriparatide plus biphosphonates or both. If every patient is having a fall, back, spine, and groin, please don't dismiss that as abrasion or surgery or trauma. We have to take two X-rays now, at least AP, DL spine that. And surgery is always more the age, patient age 80 and more the age, more is indicated for surgery so that patient can live at least few more years happily. So thank you very much. I will stop. If I got any questions regarding this, please wait.
Thank you, sir, for your wonderful presentation on osteoporosis, investigations, management, and I'm happy, as I'm a community medicine faculty, that you have mentioned about the prevention aspects also. Thank you, sir, for enlightening us about osteoporosis, the clinical features, investigations, how to manage, and the prevention strategies, and the useful take-home messages will also help the audience to know more about this condition. Thank you so much, sir.
Sir, excellent presentation, sir. Covered everything A to Z up to treatment. You have a couple of questions from floor, sir. Question one is whether the osteoporosis is reversible.
Sir, can you repeat the question, please?
Whether the osteoporosis is reversible. Whether the osteoporosis is reversible.
The osteoporosis, it is reversible. We cannot say we can make it to normal. We have to understand that this is the aging process. A lot of people ask this, but we can control it. So we cannot reduce the age. As we show in the graph, the bone density at the age of 20 is not the same as the bone density at the age of 50. We cannot convert a bone which is 50 years into a bone which is 20 years. But we can at least try to make it a little bit stronger by doing all the things. We can try to maintain the bone. We cannot say, we won't say it is reversible, but it is a controllable.
Is there any relapse after treatment? Osteoporosis treatment, is there any relapse after treatment?
Yes, the relapse will be there if you do not get the supplements properly. I mean, calcium, vitamin D supplement, because bone is a tissue that is always it is going. The constant remodeling is going. For the remodeling to happen, the constituents of the bone, the basic constituents of the bone is protein, calcium, vitamin D, you have to supplement them. Without that, new bone cannot form. So if you stop taking calcium or if you stop doing physical activity, definitely there will be a relapse. Relapse means the bone density will again go down. This is like deconditioning. If you say the muscle also, you are going to the gym activity means the muscle bulk will be there. If you do not go for after 3 months, the muscle bulk will get reduced. So deconditioning can happen. So to avoid that, we have to do regular physical activity and we have to see that our diet has got a good amount of proteins, calcium and vitamin D, or we have to supplement it. Especially in elderly, supplement is mandatory. They don't take diet properly and their absorption from the gut is also poor. So the supplement vitamin D, calcium is mandatory in elderly and we need to give treatment also. This rebound osteoporosis is more common with estrogen replacement therapy, so we don't give nowadays that. These biphosphonates, even after stopping the treatment, the bone thing we maintain for 6 months to 1 year it will be maintained. The bone density will be maintained even if you stop for. That's why we give a holiday or gap of 1 or 2 years with biphosphonates. After that, we restart again.
The last question, sir. The last question, does osteoporosis run in families?
I don't think so, but there is a genetic predisposition. It is given, but we don't consider this as a genetic disorders. But there are many genetic disorders where osteoporosis may be there, where osteoporosis may be part and parcel. But osteoporosis, as such, what we call the primary osteoporosis, we don't say it is genetic or run in families. But like we say osteoarthritis in females, it runs in families, we say. But I don't think, but in general, females, the risk is high. And wherever the estrogen, the amount of years they are exposed to estrogen, very high, very early menopause or very late menarche and other medical problems which produces less estrogen in females. So all those things can produce osteoporosis. Some of these disorders, hypoestrogenic disorders, can be genetic cause. But osteoporosis as such, we don't say as a running families.
Thank you very much for your excellent presentation, sir. Good round of applause for the presentation. So with a simple closing remarks, you take adequate diet, adequate exercise, that is in the strengthening exercise, avoidance of the alcohol and smoking. So this suffice your calcium supplement. So less than 30 years, more significant for the storage of calcium. As he said, it is like a bank balance. So improve your bank balance and don't avoid ragi and the horse gram, kollu ragi. So you take it. Even we request in the mesa also weekly once to get ragi and kollu. With these closing remarks, and thank you for this opportunity, madam.
Thank you, sir. The eloquence of your presentation has transformed a standard session into a profound exploration of human resilience and structural health. I now kindly request our Associate Professor Ma'am, Dr. Sunitha, to honor our speaker. I call upon Dr. B.R.J. Kannan, sir, to get the memento on behalf of him. Thank you, ma'am. I now kindly request Dr. Sunitha ma'am and Dr. Ram Prabhakar sir to felicitate our esteemed chairpersons of this session.
Theory finds its ultimate validation at the bedside, and we now move beyond the textbook to analyze the complexities of real-world clinical presentations. This session promises a rigorous examination of unique diagnostic challenges and therapeutic triumphs. We are honored to welcome Dr. P.V. Balamurugan sir, Professor of General Medicine, Madurai Medical College, to share his wealth of clinical acumen with us today. We also welcome our esteemed chairpersons, Dr. N.S.Sunitha M.D, Associate Professor of Anatomy, and Dr. Ram Prabhakar Sir, Associate Professor of Community Medicine, to lead this vital peer review session.
Good afternoon to everyone. So, we, on behalf of Government Medical College Dindigul, we welcome Dr. V. Balamurugan sir. So, he is currently Professor of Medicine, Madurai Medical College, and also a convener for Regional Center, NMC Regional Center for Medical Education. He did his MBBS in Madurai Medical College and MD General Medicine in Kilpauk Medical College. He had a 25 years experience in UG teaching as well as PG teaching, and he was a NMC chairperson for General Medicine Curriculum Revision. He was a Senate member of Tamil Nadu Dr.M.G.R. Medical University and working as a group member in State Quality Improvement in Medical Education under DMER, and he was associate editor in Tamil Nadu Dr.M.G.R. University e-journal. And regarding his achievements, he got selected for 2-year health research mentorship program by National Institute of Health USA and St. John's Medical College Bangalore, and he received a Best Teacher Award for Medicine from MGR University, and he had received various District Collectors Award for Best Service in 2019, 2020 and 2021. Thank you, sir. We welcome you to our college. And regarding sir, I would like to tell a few words that personally I attended his session in Madurai Medical College, and when I was working in Theni Medical College, he came as a NMC observer, and we were very much enlightened to see him presenting how he presents the topic and how he applies his clinical knowledge along with medical education, and he trained many faculties from our college and also various institutes in Madurai Medical College. So thank you, sir. We will move on to session, sir.
Thank you, sir. Thank you for a very nice introduction, sir. I'd like to start by thanking the Department of Anatomy, the team, and I'd like to also tell that Dr. Jayarani and myself are batchmates in MBBS. So, and I have and Dr. Sudha Prasanna is also my batchmate, and also Dr. Raghavan, who is in medicine, is also my batchmate. So we have batchmates, and I also like to inform the pharmacology HOD of your college is also my wife, and so she is the observer now. She is not an NMC observer, but she is observer here. So happy to be before you. And Department of Anatomy, I just like to inform. So many students might have thought osteoporosis is not for you. Hope after the 4 sessions, now you know that you have a lot to do to prevent osteoporosis or osteopenia from developing. And I'm able to see a lot of female students. And it becomes more relevant for you because females only sit till the lunch while boys leave the hall. And so still it's more relevant for you. And also my talk will be so short that your lunch will be early. That information also I give you. And my session has been made simple and lighter by the past 4 presenters. So mine will be more shorter and will be simpler. And this is a case-based presentation. Now you know a lot of things about bone. Bone is not an inert or a stone. It is very active, and we will go with this is my presentation. We will have a very small introduction which becomes very smaller because of the previous presentation. I have 6 common clinical scenarios for you to relate. Many of the scenarios has already been related, and finally 1 minute for the take-home message. You all know that osteoporosis is a very silent disease. Any other silent disease you know apart from osteoporosis? Any other silent disease? More common, easily detected. For osteoporosis detection, you need a costlier investigation. Everyone knows. Even when you have finished physiology, you can detect that disease. What is that silent disease? So, you are also silent. Huh? It is also a silent killer. Everyone knows about that disease. நான் அந்த படத்தை பார்த்தேன், எனக்கு பிபி கூடிடுச்சு. So hypertension. So that is the disease which is so silent and also causing lot of morbidity. It's another disease, so silent. Many times if you, this particular CME would have increased your knowledge to identify, detect and also treat, but that is another silent skeletal disorder, reduced not only bone mass, architectural deterioration leading to fragility of the bone. It is very clinically asymptomatic until fracture occurs. Similar to hypertension, see, until stroke occurs, patient will not come to you. He may be hypertension undetected. He will think that he will not get hypertension. Similarly, you may think you will not have osteopenia or osteoporosis unless otherwise you develop fractures. Okay, so this is another thing. And the most common initial symptoms, Sarah has mentioned all symptoms and signs. But these are some of the most common clinical manifestation or low trauma fractures. காலை லைட்டாக அப்படி பண்ண உடஞ்சிருச்சு, சும்மா அப்படி மடங்கின மாதிரி இருந்துருச்சு உடஞ்சிருச்சு, சும்மா குதிச்சேன் உடஞ்சிருச்சு அப்படின்லாம் சொல்கிறாங்கன்னா you should evaluate. Very important. And finally, the vertebral compression fracture. See, the last speaker, SAR's brother, I am very fortunate to witness 2 continuous sessions by brothers. So it itself a very nice thing. And both have become doctors and both are very good in presenting things. So I think parents require a lot of accolades for that. And so he mentioned 2 things which I will remember for my life. One, you should have a bank account, opening account. So நீங்கள் உங்கள் அக்கௌண்ட்டை நல்லா வச்சுக்கணும். இந்த 20 to 30 தான் அந்த அக்கௌண்ட்டை ஓப்பன் பண்ண முடியும், பெஸ்ட் டைம். அது ஒன்று. அடுத்து அவர் சார் ஒரு விஷயம் பாயிண்ட் அவுட் பண்ணார். Even when you have pain in the inguinal region or loin, you should take an X-ray of the spine. Okay, so there may be problems. Similarly, the vertebral compression fractures may present with acute back pain, progressive height loss. So someone's mentioning about height line, உயரம் குறையுதுன்னு சொல்கிறாங்கன்னா, you remember ஔவையார். ஔவையார் எல்லாருக்கும் தெரியும் இல்லையா? ஔவையாரை படம் வரைஞ்சாலே எப்படி வரைவோம்? இப்படி தான் வரைவோம். ஔவையாருக்கு ஐயார் ஏன் இப்படி குனிஞ்சிருக்காங்க? அவங்க பவ்யமாலாம் குனியலை. She has multiple osteoporotic fractures because of her age. So similarly, whenever height you lose, you think of osteoporosis. And hip fracture typically presents, and many times a healthy elderly person develops fractures, he develops comorbidities and he dies. So these fractures lead to death. And risk factors, as mentioned, advanced age, post-menopausal status, where estrogen is being withdrawn, prolonged, already mentioned, glucocorticoid use, endocrine disorders involving thyroid, parathyroid, and nutritional deficiencies. So early recognition is very important. Height reduction more than 4 centimeters is crucial for thing. Now we have a quiz, and you will also have chocolates. But to get that chocolate, you should stand up and answer. Okay? So C, D may look similar. ஸோ அதனால் நீங்கள் டி சொன்னையா சி சொன்னையான்னு தெரியாது. வெரி சிம்பிள். ஸோ இது 1 2 3 4ன்னு கை தூக்கணும், எந்திரிச்சு நின்று சொல்லணும். வெரி சிம்பிள் கொஸ்டின்ஸ். ஸோ அதனால் ஏற்கனவே எல்லாரும் அதை சொல்லிட்டாங்க. ஸோ ஜஸ்ட் கேன் யூ டெல் விச் ஆஃப் தி ஃபாலோயிங் பெஸ்ட் எஸ்டிமேட்டட் பர்டன்? நம்ம இந்தியா பாப்புலேஷனை மில்லியனில் யாராவது சொல்ல முடியுமா? வாட் இஸ் அவர் பாப்புலேஷன் இன் மில்லியன்? 146 மில்லியனா? 140. நீ வந்து நம்ம இந்தியன்ஸ்னால நீ க்ரோர்ஸில் சொல்கிற. ஓகே, அதை வச்சு ஒத்துக்குவோம். அதில் எவ்வளோ பேருக்கு? ஸோ இட் இஸ் 14. ஆக்சுவலி வி ஹாவ் 1430 மில்லியன் இஸ் அவர் பாப்புலேஷன். வி ஆர் 20 மில்லியன் நவ், மோர் தேன் சைனா பாப்புலேஷன். ஓகே, ஸோ how many million are having osteoporosis now? எந்திரிச்சு நின்று சொன்னால் சாக்லேட் வாங்கிக்கலாம். 3. நீ சொல்கிறியா? Okay, you give a chocolate to, answer is correct. It is 50 million. அடுத்த ஸ்லைடை பார்த்துட்டியா? Your name? Irfan. Irfan was very active. He was Irfan. So Irfan gets the first chocolate. Those who get first chocolate are not, they can't get another chocolate because they can answer. Okay. Our video le one eduthurom. Okay. So sir edukraru. Sir kila paakalani. So very nice, Irfan. So I saw Irfan very active and very much volunteering. Very good. All the best. So as he said, so what is the percentage? So it is 3.5% of Indian population of 1430 have this problem. Evolve enormous problem. And it is also something you can change. That's what said. Now we'll go to the second question. In post-menopausal women with vertebral fracture, most sensitive early bone site. If anyone wants to chocolate or anyone wants to know the answer, you can stand and answer. Yes. Yes. 2. Give him the chocolate. Very good. So it is the trabecular bone of vertebra. See, you know that trabecula is more prone for developing microarchitectural problems and to fracture. Very nice. So that's also important. So the answer is trabecular bone. What is the next one? So we know that it is more common in women. What is the ratio? எந்திரிச்சு நின்னு சொல்லணும். ஒரு ஆன்சர் இல்லை. அது எது இல்லை? 1:1 கிடையாது. 10:1 அது எம்சியூக்காக போட்டிருப்பாங்களோ அப்படின்னு தோணும். அதுவும் கிடையாது. சரி, உங்களுக்குலாம் தெரியுமா ஐஐடி எக்ஸாம் நீங்கள் எழுத போய் எல்லாத்தையும் டி போட்டிங்கன்னா உங்களுக்கு எவ்வளோ பர்சன்டைல் வரும் தெரியுமா? 63% வந்துருமா உங்களுக்கு. எல்லா கேள்விக்கும் டி அது போட்டாலே 63% வந்துடுது. அப்போ இதுக்கு என்ன போடணும்? எல்லாத்துக்குமே எந்திரிச்சு நின்று சொல்லணும். எனி ஆன்சர்? யாராவது? சாக்லேட் வில் கோ டு வித் மீ. எந்திரிச்சு நின்று சொல்லணும். ஸ்டாண்ட் பண்ணி சொல்லணும். யூ ஷுட் ஸ்டாண்ட். அதுவும் அவன போனுக்கு நல்லது. ஓகே. ஸோ எஸ், வாட் இஸ் த ஆன்சர்? சி. ஓகே, கிவ் ஹர் அ சாக்லேட். வெரி குட். ஸோ 1 in 4 only will men develop. So answer is 4 in 1. Fourth question. Can anyone expand this? But you should expand by standing. I think இந்த சாக்லேட் யாருக்கு போகாதுன்னு நினைக்கிறேன். ஏன்னா யாருக்கும் தைரியம் இல்லை அதை ஃபுல்லாக சொல்கிறதுக்கு. எனிவன்? நீ சாட் ஜிபிடியில் பார்த்துட்டா கூட நீ எந்திரிச்சு நின்று அதை கரெக்டாக சொல்லணும். ஓகே, சரி, சாக்லேட் நான் தான் கொண்டு போக போகிறேன். சரி, ஓகே, we don't have time. So it is receptor activator of nuclear factor kappa B.
Sir.
Yes, யார்?
ஸ்டூடெண்ட்
எந்திரிச்சாங்களா? யாரு?
எந்திரிமா.
சரி, எந்திரிச்சு இப்போ திரும்ப கூட சொல்லட்டும். இப்போ நான் காட்டிட்டேன், ஆன்சரை சொன்னாலும் உண்டு. கேன் யூ டெல்? சொல்லிட்டாங்களா? கொடுத்து எந்திரிச்சதுக்கே சாக்லேட். ஏன்னா உன்னுடைய போன் இது கூடிடும். ஓகே. Last question, very easy one. So this is what I want to show. See, when the Rankel receptor is attached to the osteoblast with the rank, it goes to osteobone resorption. Okay, it is just opposite to the osteoprotogenin. Okay, so this is based on this only we have developed these drugs called denosumab, a monoclonal antibody against Rankel, which blocks the osteoclast activation and helps in preventing bone resorption. இது டக்குன்னு எந்திரிச்சு சொல்லிடுங்க. வெரி ஈஸி. 4 எதுக்கு நிற்கணும்? எஸ், 2. அவங்க சாக்லேட் 2 பேருக்கும் செல்லும். சேம் டைம் எந்திரிச்சாங்க. இது வந்து அவுட்டா, இது வந்து ஆல்ரெடி எக்ஸ்போஸ்ட். See this, I want to spend a minute on this. See, most of you will be in this age soon. Okay, இப்போ நீங்கள் ஓப்பன் பண்ணும்போதே அக்கௌண்ட்டில் உங்களுக்கு 1 கோடி ரூபா போடுற மாதிரி. எவ்வளோ ரூபா? 1 கோடி ரூபாயை நீங்களே வச்சுக்கலாம். ஸோ த ஓப்பனிங் this peak bone mass you are going to achieve now. Okay, achieve it to the maximum. Okay, by being physically active, taking lot of calcium, protein and vitamin D, and also doing the exercises, you can have that opening bank account at 20 to 30 years. So this is what you should know. Now we will go to the case scenarios. It will take much less time. So உங்களுக்கு இதில் மார்க்லாம் கிடையாது, குவிஸ்லாம் கிடையாது. We'll just learn. So 62-year-old women presents with gradual onset back pain and height loss. No trauma, BMI is 21, no prior fractures. On examination, there is dorsal kyphosis. So what is your diagnosis? More than 60 years, postmenopausal, height reduction. So what is your diagnosis? What she has got? Diagnosis straightforward. Any diagnosis? Yes, very good. So it is a vertebral compression fracture. It is a very common condition. It is called postmenopausal osteoporosis. So the reason is estrogen deficiency leading to rankle activity which is increased osteoclast activation, trabecular bone loss. So these bones are the first to be involved in osteoporosis, and you lose your height, and the DEXA score for her was less than -2.5, and she had vertebral assessment. So treatment already mentioned by the previous speaker, you go with calcium, vitamin D, bisphosphonate, triparatide or denosumab depending upon the stage. And remember, when you give an biphosphonates, the fractures, when you give an appropriate person even before fractures, 47% will not develop fractures. So that is very important. So if you identify a correct person to give a bisphosphonates, you can prevent at least up to 50% of people from developing fractures. So this is what you should learn, and you should screen all women more than 65 and you can give bisphosphonates. And many times உங்க வீட்ல உங்க அம்மா அப்பா சொல்லுவாங்க எனக்கு முதுகு வலிக்குதே நான் ரொம்ப நேரம் இன்னைக்கு உங்களுக்கு சமைச்சு போட்டேன் முதுகு வலிக்கு சொல்லுவாங்கல்ல. Many of them may be more than 65, many of them may be a diabetic, many of them may be on steroids. They need this scanning and they should be given bisphosphonates. So this is what you are learn, or any other drug which is, and this is one drug which is very useful drug, which is very much useful in very high fracture risk people and with T-score less than -3, failure or intolerance to bisphosphonates, and many times glucocorticoid induced osteoporosis is a drug of choice. Now we will go to the second case, another easy case, common case. So you tell me what is the reason for this patient. 45-year-old male with long-standing rheumatoid arthritis on treatment, presents with low trauma distal radius fracture. He is a male, remember. So this case, similar case was told by the cardiologist, sir. So it is what fracture it is called? EC fragility or EC fractures, distal radius. So what is the diagnosis? What is the reason? So possibly it is due to, yes, it is a steroid-induced trabecular bone loss. Steroids produce these fractures with various causes. You can see the, due to the effect on the bone cells, decreased osteoblast function, increased osteoclast survival, osteocyte apoptosis. Calcium metabolism it affects the muscles. So you know that, or you all know that muscle loss or muscle wasting is a feature of glucocorticoids. That in turn will cause fall in already osteopenic fractures. And finally, it also causes, especially during the first 6 to 12 months of steroids. So you have started someone on steroids, the first 12 months is when maximum bone loss happens. So these are something you should know, and whenever you have a steroid specific screening, so whenever someone is more than 5 milligram per day and when they have taken for more than 3 months, the osteopenia can happen. So this is something you should remember. And for other patients, these are the screening criteria, especially in men more than 70 years, 50 to 69 with risk factors, any adult on long-term steroids, history of fragility factors, especially chronic kidney disease, hypogonadism, and rheumatoid arthritis are indication for screening. So these are the secondary causes. Already many were mentioned by the sir. So just remember glucocorticoid therapy, malabsorption syndromes, and also hypogonadism. So these are the causes. Now we will go to the case 3. 58-year woman with diffuse bone pain, proximal weakness, waddling gait. Anyone? Diagnosis? You can give lot of diagnosis. Any one related to today's presentation? Enna vargum? 58-year-old woman with diffuse bone pain, proximal muscle weakness, and waddling gait. She is not on any drugs. So the investigation revealed low vitamin D, low calcium, and high alkaline phosphatase. So what is your diagnosis now? It is a mimic of osteoporosis. What is it? Very good. யார் சொன்னது? கை தூக்குங்க. Very nice. Clinical practice la illamale yaro sollirkeenga. I am very happy. So it is a mimicker. It can mimic. It's called vitamin D deficiency osteomalacia, which mimics osteoporosis. Why I took this? Because you know how many percentage of Indian population have deficient or insufficient vitamin D? It will be more than 80%. See, once in 7 years back, 66 doctors அப்போ முன்னாடி சங்கம் ஹோட்டல் இருந்தது மதுரையில். They took a vitamin D level including me. How many out of 68 had normal vitamin D? Only 2. Only 2 out of 68 doctors had normal vitamin D. Okay, these are the reasons. Limited sun exposure. What is the classical time in which you should get exposed to not to develop? It is between 10 a.m. to 2 p.m. when you will be in the office. Okay. So that is the time when UV rays will give you the vitamin D. So limited sun exposure, indoor lifestyle, cultural clothing practice, dietary deficiency, aging skin, and also malabs. You should remember, if any one of you should take some effort to increase your vitamin D. And elderly people, postmenopausal, patient with chronic illness, individual poor nutrition, long-term anticonvulsant therapy. So these people can develop vitamin D deficiency. You should keep in mind. And preventive strategies, adequate sunlight exposure, vitamin D. See, many of the foods in Western countries are fortified with vitamin D. It is not so in our country. Routine supplementation, high risk, and screening in symptomatic. This should be done. And this is vitamin D deficiency. Calcium is low, phosphate is low, ALP is elevated, and prothrombin is elevated. But in osteoporosis, serum calcium and vitamin D are often normal. So whenever you see a decreased calcium, decreased phosphate, increased ALP, you are dealing with osteomalacia. So that is what you should, which can mimic this. So now we will go to the case 4. 38-year woman presents with early menopause. What is the clinical relevance? So what has happened to her? What has failed? What has failed? Which organ has failed? Which organ? Anyone? Okay, very good. So it is nothing but, so she has developed premature ovarian failure. She has no history of fracture, but she is at a significant risk of early bone loss and future osteoporosis. So premature ovarian failure defined as loss of ovarian function before the age of 40. So this you should remember. Many times they may neglect that because they are prone to develop osteoporosis. So the estrogen deficiency results in increased osteoclast, I said, mentioned previously. So here, because of premature ovarian failure, the bone loss begins 10 to 15 years earlier. So what you should do? You should treat them. And when to screen? So at the time of diagnosis of premature menopause itself, you should screen. And if additional risk factors are present, you should screen. And you should, when BMD is normal, you need not treat them, but you should check it again. So what is the treatment for them? There is a hormonal replacement therapy is going to be helpful, and these patients may benefit by like this: prevents accelerated bone loss, improved bone mineral density, and there is a treatment and recommended duration till when they will reach their real menopause. You should give up to 50 years. And you should also know that the typical regimen is estrogen, and if estrogen in the uterus is present, progesterone can also be added. So what we saw in the case 4 is premature ovarian failure. It makes them premature osteopenia and porosis. So now this is the another case, 65-year-old woman, recurrent vertebral fracture, but DEXA scan is normal. Why? Kyun? So DEXA scan shows osteopenia. Okay. The scenario highlights important concept that metabolic bone disease fracture site is determined not only by density but also the quality. Okay. So you should also look at it. Bone density we measure using DEXA, but bone quality we are not able to measure. That is also important. The trabecular bone structure You can see this already, SAR gave an electron microscope picture. They become thinner. If BMD reduction is mild, loss of trabecular connectivity can significantly weaken bone. So, some individuals with osteopenia also develop fractures. So, some with osteoporosis can be fracture free. You may be diagnosed with osteoporosis, but you will not have fracture. There will be a person with osteopenia may develop fracture because of the microarchitectural problem. And there are some tests like trabecular bone score and clinical research FRAC score that you can also will tell you whether even with osteopenia or normal BMD you can have this abnormality. So now we go to the last case. So this is a very common case. 72-year-old woman with diabetes mellitus hypertension presents with trivial fall. Sir sonarla trivial fall. Elderly female. What is the clinical relevance of this case today? What is the relevance? We all know that postmenopausal women will have fractures. So whenever a patient has fragility, these are called fragility fractures, occurring with minimal trauma, from the fall from standing height or less or underlying skeletal due to osteoporosis, so you should think of diabetes itself. It's a notorious country. You know which country is capital of diabetes? India. Which is the capital of diabetic nephropathy? India. Diabetic foot amputation? India. So diabetes-related osteoporosis also should be India. So these are the various regions. Advanced glycation end products can lead to accumulation of AGEs in bone collagen, making them more brittle. Reduced bone turnover and microvascular changes all can lead to, and another important thing which we are facing now is called sarcopenia. So many of the drugs we are going to taking for obesity can also have sarcopenia. And this sarcopenia is called age-related loss of muscle mass, and along with other factors can lead to lot of fall. And diabetes, apart from causing osteoporosis, can also cause sarcopenia. Both together can produce impaired balance, slow gait speed, reduced reaction time, and can lead to this. That's why they say osteosarcopenia. In diabetes, what you get is called osteosarcopenia. So you should keep in, you can see especially very uncontrolled diabetic patients will come lean. Weight குறைஞ்சிருச்சு சார், நான் இப்போ கொஞ்சம் நடக்க ஆரம்பித்தேன், வெயிட் குறைஞ்சிருச்சுன்னு சொல்லுவாங்க. அவங்க நடக்கலாம் ஆரம்பிக்கலை, அப்படியே தான் இருக்காங்க. Because of uncontrolled diabetes, they have lot of sarcopenia, and now they have osteosarcopenia. So you should keep these in mind. So diabetes increases the fall risk because of various reasons: peripheral neuropathy, impaired proprioception, visual impairment, retinopathy, hypoglycemia. So remember this, diabetic patient, elderly postmenopausal, has multiple reasons to develop osteoporosis. So now I have a last 4 slides. 1-page clinical algorithm. இது வரைக்கும் நீங்க படிச்சதெல்லாம் 4 slide. Number 1, step 1, identify the risk. Postmenopausal women, age more than 65, steroid use, chronic illness, previous fragility factor. This is step 1. If you find any one of these patients, then evaluate them. You look for all these things or most relevant things or appropriate things. Next step, classify them. Low BMD, normal biochemistry, osteoporosis. Low vitamin D, high ALP, osteomalacia. Fracture despite osteopenia, clinical osteoporosis. So we have non-pharmacological treatment, already mentioned, lot of exercises, fall prevention, nutrition optimization. Pharmacologic management, we have this. And these are the pharmacotherapy, calcium and vitamin D optimization. So these are various things you can do. And this is something called bone healthy lifestyle. If at the end of this CME today or CEP today, if you know that there is something called bone healthy lifestyle, and if you are able to do weight bearing exercise, resistant exercise, and adequate intake of calcium, you are becoming a bone healthy person. And regarding this resistant exercises, nowadays it is very much important. See, when you are doing exercise for 7 days a week, 4 to 5 days you do something called weight bearing exercise, 2 to 3 days go resistant exercise. Not only for your bone, for your insulin sensitivity. So that is a very important thing you keep in mind. So this is the step 5. If it is normal, repeat after 1 to 2 years, adhere to your exercise program, and you do this fall risk assessment. So we have come to the last slide. So there are some take-home messages which you know. I'm just repeating. Osteoporosis is preventable and treatable. You can prevent it. At your age, you can prevent it. If your parents have osteoporosis, it's treatable. Osteoporosis is often diagnosed after fracture. Remember it. All fragility fracture is a diagnosis of osteoporosis. Every fragility fracture is a missed opportunity. If someone comes to you with fragility fracture, it means they have missed it. And vertebral fractures are frequently under-recognized. So many times you take a spine, accidentally you will see some fragility fracture healing. Many times it's missed. And fracture begets another fracture. Today one fracture, tomorrow you have another fracture. Bone mineral density alone is not a definitive test. எனக்கு BMD normal இருக்கு பத்தாது. You have frac score. You should be very careful and look for it. Secondary causes you should all remember. At least you remember some of the drugs can cause it. Management must be comprehensive and it should be individualized. So there may be a same age, same work, but there may be different genes, different food intake. You should remember that. Early diagnosis can reduce mortality as well as disability. Thank you for your patient listening, and also I thank once again for the team anatomy for giving this opportunity, and I also thank the participants for not sleeping in spite of the time crossing 1, and also those who are enthusiastically participating in the questions. Thank you once again.
Thank you, sir. Thank you, sir, for sharing the wisdom of your experience. You have provided the intellectual framework upon which we will build better patient outcomes. I now kindly request our HOD ma'am, Dr. Jayarani ma'am, and Dr. Jayapriya ma'am, Professor and Head of Pharmacology, to felicitate our speaker.
I request the Trilochandran sir, Associate Professor of Surgery, to join with us.
I now kindly request Dr. Tirulokachandran sir, Associate Professor of Surgery, to felicitate our esteemed chairpersons of this session. I now request Dr. Jayarani ma'am to felicitate Dr. Tirulokachandran sir.
My special thanks to our Tirulochandran sir for very good support from 2021 onwards, and he is the only clinician waiting here to observe this meeting. Thank you, sir. Thank you for your excellent support, sir. Thank you, sir.
The curriculum starts with the A, that is anatomy. In a clinical side, it starts with the A, that is anesthesia.
Sir, we are extremely honored to have Dr. Balamurugan sir here. Thanks, sir, for your short and very sweet presentation. As always, it was very lively and informative session. And all case scenarios were extremely helpful. And I think it will be very much helpful for our future doctors here. And you made learning about osteoporosis in a very interesting and interactive way, sir. By conducting quiz and distributing chocolates, you proved that you are a regional center MU coordinator, sir. Thank you.
We are pleased to welcome Mutturaj sir, HOD and Professor of Surgery, GMC Dindigul. I kindly request Mutturaj sir, HOD and Professor of Surgery, to chair the session.
Happy to share with you, Da. I would like to receive feedback from the student side, because I think everyone took part very nicely and given a more support to us, and our department also taken a many steps to implement this program. So if you share your feedback, if there is a plus or minus, we will try to improve it. How many batches are there? Sri Dashni, சொல்லுடா. Isaki Ammal also can share the feedback.
This was indeed an extremely useful session organized by the Department of Anatomy, especially the clinical case-based scenarios which were discussed were of immense use and importance to us. And thank you, ma'am, and the department for organizing this. We expect more from the Department of Anatomy.
Thank you, ma'am, for organizing such a session, ma'am. It was very useful. Like from the start, I was able to recollect and revise the teachings which related to embryology and in pathology, everything, ma'am. The clinical based scenarios were very useful. So I would like to say that if any other in the upcoming years, if CME was conducted, I would like to add case-based scenarios in each session, ma'am. Thank you, ma'am.
Sir, we welcome Professor Sudhakaran sir to the stage. He is currently the HOD of the Department of Radiodiagnosis in Government Medical College. He did his undergraduate at Coimbatore Medical College and post-graduation at Madras Medical College. And he is doing an extraordinary work in our department, both interventional radiology, and he has got number of publications in national and international journals. And we welcome you, sir, for today's topic. The topic is dentistatus oocyst. Welcome, sir.
Before discussing about the bone density, we will discuss about the clinical features and the pathological features and the various conditions associated with the osteoporosis and osteopenia. The osteoporosis is characterized by the decrease in cortical thickness and in the number and size of trabeculae of the cancellous bone. The cortex will look thin and the trabecula will look sharp in the radiograph with non-uniform deformity, spinal deformity. Shade over the screen. Whereas the osteomalacia is characterized by impaired mineralization of the osteoid and the ratio of the organic matrix to mineral is increased, and the coarse and indistinct trabecula in radiograph with uniform spinal deformity. Okay. Then the WHO definition for the osteoporosis is, it is a skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue with consequent increase in fragility of the bones and susceptibility to fracture. The major advancement in the field of radiology is the non-invasive, accurate and sensitive assessment of the bone mineral content determining the risk of fracture before it occurs. So there are various causes of the osteoporosis. Before that, it is classified into generalized, regionalized and localized. That is, generalized means entire skeleton will be involved. The common causes are the generalized malignant bone diseases, senility, post-menopausal women, and the other causes, general causes are the alcoholism, hypothyroidism, hyperparathyroidism, steroids, drugs, etc. Then the regionalized osteoporosis means either a limb or a
particular skeleton is involved, particular part of the skeleton, entire skeleton is involved. A part of the entire skeleton is involved, as in cases of immobilization. Due to spinal fractures, some patients will be immobilized, no? They will develop osteoporosis of the lower limbs due to immobilization. And the other regionalized causes are the migratory osteoporosis, transient osteoporosis, and the Sodex osteodystrophy. Then the localized causes may be local infection, inflammation, and neoplastic conditions. So the generalized causes, as I mentioned, few causes. Among this, the most common cause is the senility, postmenopausal, and it is due to the resorption of the cortical and the medullary bone, which results in the thin cortex and the trabecular alteration. Remember, the cortex will be thinned and the trabecular pattern will be lost in osteoporosis, whereas these things will be maintained in cases of osteomalacia. It is due to insufficient mineralization, osteomalacia. Okay. So, what are all the bones, which bones are all involved, which are all the important findings we have to see in osteoporosis? In the spine, there may be deformities such as the biconcave vertebrae. The vertebra gets collapsed and gets into a coin-like structure, vertebra plana, small snode we can have, pseudo-hemangiomatous appearance of the vertebral bodies. And in the pelvis, we will see the femora. I'll come to this into later with a picture. Then there will be insufficiency fracture. Even a trivial injury can cause fracture to the osteoporotic patients. Especially it involves the femoral neck, tibia, fibula, pubis, etc. Then the additional features, the most commonly the fractures are associated elsewhere in the radius also, humeral neck and ankle malleoli. See the pictures of diffuse osteoporosis involving the cervical spine. See, the bone density is lost, the cortex is thinned out. Then the trabecula is entirely lost. There will be vertical and horizontal trabecula. The vertical are the compressile and the horizontal are the tensile trabeculae. These are totally lost in diffuse osteoporosis. This is the pseudo-hemangiomatous appearance. Whereas in hemangioma, only a single vertebra or one or two vertebra will be involved. Whereas in osteoporosis, entire vertebra will be involved, no? So, the trabecula will, tensile trabecula will be lost. Only we will see vertical trabecula. And in later stages, these trabecula will also be lost in severe osteoporosis. These are the insufficiency fractures. Patient might have had a trivial fall while walking, and these fractures are involving hairline fractures, undisplaced fractures involving bilateral sacral ala. This is on bone scan. It is looking like a H-shaped. This is Honda sign of bone scan of insufficiency fracture of the sacral ala. So, regional osteoporosis, as I said, this is the sympathetic dystrophy, wherein the part distal to the trauma will get osteoporotic due to neurovascular imbalance that is promoting osseous hyperemia. And the radiological features include the osteoporosis, decreased density of the bone distal to the site of the fracture. Then the disuse osteoporosis, as I told, when limb is not used for longer time by more than 2 or 3 months, that limb will go in for osteoporosis due to disuse. Then the transient or regional osteoporosis is a transient phenomena which occurs most commonly in pregnant patients. Most commonly the femoral neck, femoral head is involved more than the neck and the trochanterus. This is more commonly affected in the hip joints. Okay. The case of Sodex osteodystrophy, this patient had a radial neck fracture, distal radial fracture. The hands showing the distal the metaphysis of the metatarsals and the phalanges shows osteopenia. So far we saw about the osteoporosis. Now we will see something about the osteomalacia. As I told, it is due to improper mineralization of the osteoid matrix. Okay. So, insufficient, delayed or defective mineralization of the cortical and spongy bone. There are abnormal quantities of inadequately mineralized bone matrix called the osteoid. The mineral, where will the mineralization occurs? It occurs on the surface of the trabecula and the lining of the cavation canals. These are called the osteoid seams. So these structures will look less dense. So osteopenia is the most common sign due to the decreased bone mineral content. It involves uniformly. Okay, the coarse distinct trabecular pattern will be maintained. Okay, overall decrease in the number of bony trabecula will enhance the remaining trabecular appearance. Okay, the cortical, thin cortices on the endosteal surface is characteristic of osteomalacia, and this condition is characterized by pseudo fractures, otherwise called as the looser zones or the umbo zones. Okay, these are linear areas of undermineralized osteoid in bilateral and symmetric distribution at right angles to the cortices. I will show in the images. So these are the insufficiency fractures involving the pubic symphysis and the neck of the scapula, looking linear perpendicular to that of the cortex. So looser zone is characteristic of osteomalacia. The characteristic sites are the margins of the bones, especially the membranous bones, the axial margins of the scapula, superior inferior pubic rami, inner margins of the proximal femur, posterior margins of the ulna. The insufficiency type fractures are due to vascular pulsations acting on the softened bones. Without trivial trauma also, the patient will get these looser zones due to vascular pulsations, due to extreme osteopenia of the underlying bone. Okay, it do not necessarily involve the weight bearing bones or remain unaltered. It remains unaltered over longer periods of times. See, this is again the increment fracture of the umbo zones. The true fractures may develop at these sites of umbo zones in the later stages. Mild to moderate sclerosis with the absence of callus. There will be absence of callus. When there is osteopenia, how come the callus will happen? Okay. Similar radiolucent areas may be seen in Paget's and fibrous dysplasia also. The osteoid laid down in the replacement process is inadequately mineralized, accounting for the radiolucent appearance. So how will we analyze the bone density radiologically? There are several modes. Okay. Switch off. There are several methods of imaging available for the bone mineral analysis. Among this, we commonly use the radiography. We commonly use X-rays or day-to-day OP procedures we are doing. Then among that, these single and dual photon absorptiometry methods are now outdated. Okay. These are all Compton scattering, neutron activation are all under research processes. Then the DEXA scan. In some centers, the dual energy X-ray absorptiometry has been done, but it has certain limitations. I will come to it later. Then the quantitative CT, dual CT, single slice CT, dual CT, these also have certain limitations. Okay. Now the latest techniques are the multi-detector CT, which is very comprehensive, very sensitive in detecting the bone mineral density. By MRI also we can detect the bone density, but the most appropriate is the multi-detector CT, followed by the quantitative CT, followed by the dual energy CT, followed by the X-ray. Okay, we come to it one by one. So the bone density should be reduced to at least 30% to detect the osteopenia. Okay. So there will be what are all the radiographic findings? There will be generalized osteopenia, thinning and accentuation of the cortices. Cortical thinning, loss of trabecula are the main features, diagnostic features of the osteoporosis. Changes in the vertebral body shape, as I showed. As I told you earlier, there will be concave vertebra, biconcave vertebra, fish-shaped vertebra. There will be small nodes, thinning of the end plates, loss of trabecula. Okay. Then there will be insufficiency fractures due to extreme osteoporosis, and followed by wrist and hip fractures, which are more common in the elderly patients. So by looking at the X-ray of the hip joint, by looking at the trabecula, we can assess the severity of the osteoporosis according to the Singh index. As we all know, the head of the trabecula, head and neck of the femur consists of primary compressile and the primary tensile trabecula. These two are more important, and the secondary compressile and the secondary trabecula. Okay, by increasing order of severity, see the compressile trabecula is seen, whereas the tensile trabecula is progressively not seen. Here the compressive trabecula, primary compressive trabecula is the last thing to get lost. Okay, in severe osteoporosis only the primary compressive trabecula will get lost. See, in grade 5 means normal, grade 4 means the secondary tensile is lost, and grade 3, grade 2 and all, progressively the primary trabecula, primary tensile, primary compressive trabecula are also lost, so that we can grade the severity of osteoporosis using the Singh's index. Okay. This osteoporosis in radiograph, what means see the vertebral body height is reduced, there is vertical compression fractures, okay, diffuse osteopenia, secondary degenerative changes, end plate thinning, cortical thinning, loss of matrix, everything. Okay, entirely the skeleton is very radiolucent. Okay, in these legs also the distal tibia, fibula and the calcaneum is also showing less density due to osteoporosis. Okay. So single energy photon absorptiometry, as I told, it is an outdated modality. Okay. Just to know about it, it requires a gamma ray source, and the radius is measured at two sites, mid diaphysis and the distal metaphysis. Okay. It only uses low energy gamma source, and the body parts thicker than the distal forearm cannot be measured using this single photon absorptiometry. So dual energy absorptiometry uses isotope that emits photons at two different energy levels, that is 42 and 100 Ke levels with uniform path length. It yields integral of all mineral within the scan path, not only body, end plate and posterior elements, but also the callus, facet hypertrophy, discogenic, that everything, whatever the path in which the gamma rays passes through, it detects the entire mineral amount in that course. So it is also used to determine the total body mineral content. So we will come to the dual energy X-ray absorptiometry. It we rely on the T value. T value should be more than or equal to -1. Okay. When it is -1 to -2.5, it is osteopenia. When it is less than or equal to -2.5, then it is severe osteoporosis. The patient is more prone for fragility fractures. Okay. It is based on the measurements made at the lumbar spine, proximal femur and the forearm, and not other anatomic sites. Okay. Please note this point. It is made at the lumbar spine, proximal femur and the forearm only. Okay. It uses fan beam scanners, use wider beams that permit more rapid scanning, that is 3 to 5 minutes per site. Spine 3 to 5 minutes, then femur 3 to 5 minutes, then forearm. So, with improved image quality and spatial resolution of 0.5 to 0.7 millimeter, it can detect. Okay. Dividing body mass, bone mass content by the projected area of the measured site gives the bone minerals density in grams per second square centimeter. The risk of fracture increases approximately 1.5-fold for each standard deviation decreased from age adjusted bone mineral density. So, in DEXA, what is T score, what is Z score? T score describes the difference between the bone mineral density of the patient being examined and the mean bone mineral density of a standard young adult population of 20 to 30 years. Okay. Whereas the Z score is the difference between the patient's bone mineral density and the mean bone mineral density of the age and gender matched controls. It is particularly important in patients aged more than 75 years. So, what are all the limitations of DEXA? It is two-dimensional technique. So, it cannot distinguish between cortical and trabecular pattern or discriminate between changes due to bone geometry. It cannot help in those with increased bone density within a fixed bone volume. Okay. Systematic overestimation of the density in larger bones and underestimation of the density in smaller bones has significant effect on the area of bone mineral density. Okay. So, quantitative CT, dual CT, so single energy, single slice, double slice CTs. What are these? There are several advantages over the other modalities where we said about the single photon emission for then the dual energy absorptiometry and the DEXA. Comparing to these modalities, what are all the advantages of quantitative CT? It expresses transaxial display of data permitting identification of the anatomy and separate measurement of the cortical, cancellous or integral bone mineral density. Capability of determining linear absorption coefficient for a readily defined volume of bone and measure of density. In dual energy mode, ability to determine mineral content with high accuracy in presence of variable fat and soft tissue content. See, look into this factor. The dual energy, wherever the gamma rays passes, it will measure the bone density along its path, whether it is a callus or osteophyte or a bone tumor or osteoma. It cannot, whether a soft tissue calcification, it cannot differentiate between the structures. Whereas the quantitative CT, we are doing cross-sectional imaging. So, it can differentiate various structures and we can measure the density of the at the desired part of the bone. Okay. We need not measure the soft tissue and wherever the rays passes. Okay. This is the main advantage of the CT, quantitative CT. Okay. So, these are the advantages of the quantitative CT over the DEXA as I mentioned. Okay. It is sensitive in measuring the changes over a short follow-up period. Then possibility of selectively measuring the trabecular tissue and the most metabolically active area of the bone, which is the most active area of the bone. It is the compressive strength, the compressive trabecula. In the primary compressive trabecula, as I told, these are the most metabolically weight-bearing areas of the bone, which determines the osteoporosis, clinical features of osteoporosis. Okay. So, as I told, there are certain disadvantages of the quantitative CT also. Okay. What are all the disadvantages? The accuracy of the bone mineral density decreases in elderly patients by 20 to 25%. Okay. It involves high radiation dose, poor precision, high cost, and it is operator dependent. Okay. It needs considerable space, scanner access, and it is used only for, note this point, only for spine volumetric bone mineral density. Okay. So the most advantageous, most recent, highly sensitive, easy technique is the multi-detector CT. Multi-detector CT, recent innovation. Okay. In normal Indian female, the bone mineral density in MDCT is 217.87 minus 1.6 into age of the patient, and normal male is the 221.01 and minus 1.5 into age of the patient. So the bone mineral density is 0.77 into mean bone density of the MDCT. Okay. We look at these factors where BMD MDCT is the average of the densities of L1 to L3 vertebra calculated on spiral CT, and 0.007 factor is the conversion factor. Okay. With the advent of the MDCT, it enables, as the quantitative CT, it analyzes only the spine, whereas the MDCT analyzes the hip, a clinically important site of fracture which is not possible in quantitative CT due to poor precision. Okay. So with the MR also we can calculate the cortical bone, but it is very little precise comparing to MDCT. It is not commonly done. Okay. Okay, doctors. I thank my Dean, MS Sir, AMS Sir, RMO, ARMO Sirs for giving me this opportunity. Thank you, one and all.
Thank you, sir, for sharing the wisdom. Thank you, sir, for sharing the wisdom of your experience. You have provided the intellectual framework upon which we will build better patient outcomes.
Thank you, sir, for your wonderful presentation and making the elaborate presentation about the differentiation between the osteoporosis and the osteomalacia and the various methods for the diagnostic purpose of the osteoporosis. Thank you, sir. Thank you for your acceptance and deliver the message. Thank you, sir.
I now kindly request our Associate Professor Ma'am, Dr. Sunitha, to honor our speaker. Thank you, ma'am. I kindly request Dr. Sudha ma'am, Associate Professor of Dermatology, and Dr. Vinod sir, Assistant Professor of General Medicine, to felicitate our esteemed chairperson of the session.
I happy to announce about our anatomy art competition conducted online for all phases of MBBS students in various college at state level. In digital art, the third prize goes to Priyanka Bharati 2022 batch, phase 3, part 2 MBBS, GMC Dindigul. Then second prize goes to Manasa M 2025 batch, phase 1 MBBS, Madurai Medical College. First prize Rabita RT 2023 batch, phase 3, part 1 MBBS, Stanley Medical College. The prize amount is 1,500 for the first prize and 1,000 rupees for the second prize and 500 for the third prize. Bone Health Awareness Slogan Contest, third prize ST Reshma 2025 batch, phase 1 MBBS, GMC Dindigul. Second prize Abdul Bashit 2025 batch, phase 1 MBBS, Velamal Medical College. And Dharani Niti 2025 batch, phase 1 MBBS, Government Sivagangai Medical College. Patient Education Leaflet Design, third prize Sri Darshini 2023 batch, phase 3, part 1 MBBS, Government Medical College, Dindigul. Second prize Ajay Sabunan 2022 batch, phase 3, part 2 MBBS, KAP, Vishwanathan Government Medical College, Trichy. First prize Sarvesh Ram 2023 batch, phase 3, part 1 MBBS, Government Coimbatore Medical College. Okay. I congratulations for all the winners and the participants. Thank you.
We now request our HOD ma'am to felicitate the winners. ST Reshma 2025 batch, Government Medical College, Dindigul. Third prize for Bone Health Awareness Slogan Contest winner. We also request Balamurugan sir and Muttaraj sir to join the stage. Third prize winner for Patient Education Leaflet Design, Sri Darshini M 2023 batch, phase 3, part 1 MBBS, Government Medical College, Dindigul. As the curtains fall on the academic session of OSTEOPREV 2026, we find ourselves standing on a far more resilient foundation than we began. To our distinguished speakers, you have done more than merely present data. You have articulated the very poetry of human anatomy and the vital signs of its preservation. We extend our deepest gratitude for the brilliance and clarity you brought to this forum, turning complex clinical challenges into a shared vision for prevention.
I now kindly request our respected Associate Professor of Anatomy, Dr. Sunitha Ma'am, to deliver the vote of thanks.
I am here for the vote of thanks. Respected Dean Sir, esteemed MS Sir, VP Sir, RMO Ma'am, distinguished speakers, my dear colleagues, and above all, my dear students, a very pleasant good afternoon to all of you on behalf of the organizing team. It is my privilege to deliver the vote of thanks for today's CEP program. First and foremost, I would like to express our sincere gratitude to our most respected Dean Sir for his constant motivation, inspiration to conduct today's program. Thank you, sir. Your guidance and leadership made this program possible today. Thank you, VP Sir. You have been a great support as always in promoting and enhancing all our endeavors. Thank you, MS Sir, DMS Sir, RMO, ARMO Sirs for your administrative support in coordinating this program. Our sincere thanks to all the HODs, associate professors, assistant professors, tutors, senior residents from various colleges and our college who have made their esteemed presence here. We would like to express our heartfelt thanks to the resource persons and our honorable speakers who shared their valuable knowledge and clinical experiences. Today's discussions reminds us that every great clinician begins with a strong foundation. I'm sure that your insights we gain today will definitely guide our students from dissection hall to compassionate patient care. We thank all HODs and faculties from various government and private medical colleges throughout the states who promoted and made the students to participate in our inter-college competitions held statewide. Thanks to all the participants, postgraduates and undergraduates who poured in their registrations to make this event a successful one. A special word of appreciation goes to the beloved Government Medical College Dindigul students, first year and all the other phases of students. Your active participation kept this program vibrant and very lively. Thank you, dear students. Finally, we extend our gratitude to all our anatomy assistant professors for their technical support and their excellent teamwork. Not to leave the crystal workers and other supportive staffs and all other who worked behind the scenes to make this event a successful one. As to conclude, let us remember that from the dissection table to the patient bedside, anatomy remains the language of medicine. Today's learning will be definitely a guide to our future budding doctors. With these words, I conclude my vote of thanks. Thank you all.
I kindly request everyone to come to the stage in order to take a snap.